Good morning, everybody. I have been assured that we don't have to use microphones in this room. So, Dr. Jarrell, thank you very much. It's the first place we have not had to be consistent about microphone use. So we've got mics in the ceiling. I'm assured that they're picking us up online and we're going to be able to hear them. So hopefully we can all hear each other. Thank you all for being here. Welcome to Tillamook. I hope you have had even a moment to enjoy the beautiful weather, and welcome to campus. Happy to have with us Senator Suzanne Weber, who represents the North Coast District and is also a board member here at Tillamook Bay Community College. And Dr. Paul Jarrell, thank you for having us. I didn't ask you if you wanted to say any welcoming remarks.
Welcome.
Yes, excellent. We're going to hear from Paul a little bit later for one of our panel conversations, but we're really excited today to hear about progress on their new healthcare education building. So lots to dive into today. So let's see, let's go to the next slide, which I think is walking us through the agenda. We'll start with some opening remarks from our leadership team and do some introductions. I believe that with folks listening online, we do have a quorum, so we will be able to approve our June meeting minutes. We do have an opportunity for public comment if anyone has signed up for that. Sarah Means from the governor's office will be joining us, but she can't join us until 10. So we're going to do a little swap in the agenda. But she will be with us. I don't know that she's introduced herself to this consortium yet, new in her position with the governor's office, and she'll be providing some updates on the Behavioral Health Talent Council, as well as some other pertinent information. Gail is going to walk us through a recent release from the Employment Department. I shared with you all the press release and the full report a couple of months ago, I believe, and Gail and I talked about making sure we got that on our agenda. So it is the growing demand and workforce needs in Oregon's healthcare and social assistance sectors. So she's going to kick us off today with her presentation. Then we're going to have the opportunity to hear from some regional employers. And I really encourage you to think about questions that you might ask employers from Astoria to Tillamook. We've got some folks from Astoria, some folks from Seaside. Just thinking about what is it like to encourage, recruit, retain a workforce in a rural part of Oregon. And so that panel will be facilitated by Becky. Thank you so much. And then we're going to have a brief group discussion to just start to socialize some ideas about what our priorities for 2026 will be. And then we're going to have the opportunity to hear from one of our Future Ready grant recipients, the Nehalem Bay Health Center and Pharmacy. They'll be talking about their scholarship program. A few of us had the opportunity yesterday to tour their new facility, ribbon cutting in a couple of weeks, and it's just a remarkable asset here on the North Coast. So looking forward to hearing from them. You will get the opportunity to have a little break to grab some lunches, and then Dr. Bennings will be facilitating a panel on the Tillamook Bay Community College Healthcare Education Program with community partners. So we'll get to hear more about the new facility and the partnerships and what that means to a community like Tillamook County. So without further ado, I would like to start by introducing your new healthcare consortium strategist. I sent you all a little brief bio on Daria Curtis, who is sitting right here. I told her to smile and wave. And I promised I would take all the hard stuff today. So she's been with us for almost 4 weeks now. Yeah, and we're just could not be more excited about what Daria brings to the position. But she comes to us most recently from Immigrant and Refugee Resettlement Services in Lane County, and prior to that was at the University of Oregon and So we're thrilled about what she's going to bring to the position, and I encourage all of you to take some time to introduce yourself to her today while we're here in person. So let's start with just a round of introductions, and then we'll jump into our agenda. But we've got some guests with us. I want to make sure everyone knows who's in the room.
Hi, I'm Gail Krummenauer. I'm the State Employment Economist at the Oregon Employment Department.
I'm Rob Whittingham from Western Oregon University.
I'm Melissa. I'm here with SEAU Local 503.
Becky Holtberg, Hospital Association of Oregon.
Adrian Bennings with Portland Community College.
Marin Ariela, I'm part here as a member of the Governor's Racial Justice Council. And I want to brag about this, Jennifer. I was co-chair of the committee that created Future Ready Oregon with Jennifer back in 2002. Was it 2002?
22.
Oh, 22, right. I'm very proud to be part of that committee and part of the work that Jennifer and staff have been doing, and looking forward to working with you all. Thank you.
Dari Burgess, Healthcare Industry Consortium Strategist with the Higher Education Coordinating Commission.
Hi, Neelam Gupta. I'm the Director of Clinical Supports, Integration and Workforce at the Oregon Health Authority.
Good morning, I'm Denise Stallman, Assistant Vice Provost for Workforce Capacity Development with OHSC.
Cheryl Cohen, Traditional Health Workforce Manager at Pacific Source Health Plans.
Good morning, everybody. I'm Liz Rain, and I'm over at the Oregon Department of Education. I support career and technical education in our high schools and primarily the health sciences.
Great. Emily, you want to introduce yourself?
Good morning, everybody. My name is Emily Zuber, and I'm the Office Specialist for Future Ready Oregon, and I help with public meeting administration for the consortium.
And Elaine.
Good morning, everyone. I promise I'm not a shadow. My name is Elaine Collins. I am a workforce ready grant shipper.
Thank you. All right, let's have our gallery introduce yourselves. Many you'll see later today, but
Good morning, everyone. Gail Nelson, the CEO of the Nehalem Bay Health Center and Pharmacy. It's a pleasure to be here today. Thank you.
Good morning, Paul Gerald, President here of Tillamook Bay Community College. Well, glad to see our growing campus and also a board member on the Tillamook Bay Health Center and Pharmacy.
My name is Maria Carrillo, and I'm the Pathways to Equity Coordinator, which is what we're calling the Future Ready Oregon locally.
Suzanne Weber. I live here in Tillamook, so this was an easy trip here. I want to welcome you all. It's nice to have you here. My district, Senate district is Tillamook, Clatsop, Columbia, rural Multnomah, rural Washington, and part of Yamhill County. And so I scatter myself throughout the area, but I'm really glad that you're here in Tillamook. This really means a lot. Thank you.
thank you. Jeanette.
Good morning. I'm Jeanette Schecker. I'm the Director of Operations at Columbia Memorial Hospital in Astoria, Oregon.
Thanks for being here.
Good morning, everyone. Charlie Hansen, I'm a policy advisor in the Office of Community Colleges and Workforce Development at the HIC.
Thank you. Okay.
Hey, everybody, I'm Logan Garner. I work for Northwest Oregon Works, the Workforce Development Board for Clatsop, Columbia, and Tillamook and Benton counties. I'm here to just listen and take a lot of notes. So,
Thank you.
Good morning, my name is Anya Reeser, and I'm the COO for Tillamook Community Health Centers locally. So really excited to be here and just listening in as well, and our partners.
Thanks for being here. Shauna.
Hi, I'm Shauna Dennis. I'm the Technology Industry Consortium Strategist.
Hi, everyone. I'm Laura Idem. I'm the Communications Specialist for the Future Ready Oregon.
All right, I think that's everything. Well, we will dive into our consent agenda. Have you all had a moment to review the meeting minutes from June? Any questions, comments, corrections? And Elaine, for folks that are listening in, if you have any questions or comments, you can put them in the chat and Elaine will flag those for me. I'm not going to make you hold up red, yellow, and green cards this time. So if someone wants to make a motion.
I'll make a motion
to approve. Okay, as presented. Any objections? Seeing none, then we will advance the meeting minutes as presented. Do we have anyone signed up for public comment? No. All right. Then with no public comment, that moves us even more quickly to Gail.
All right.
Are you ready?
Let's
Do it. All right, so Gail is going to get us started and then we'll get back in line with the agenda. Thank you.
Right, I'm just gonna stand up here. As you can all see, can the mics catch me if I'm over in the corner? Am I good? Nobody say I'm not. All right, good morning again. My name is Gail. Thank you for asking me to be here and share. I'll admit it's a little bit intimidating to stand in front of this room and talk about this because I feel like any of you could stand up here and give me a few lessons about what's going on with the healthcare workforce. I guess one thing, silver lining, that I'm a bit comforted by is that since most of us have been around for the past 12 years, several of you are aware of some of the rails and or limitations and or boxes that this data lives in, and that it doesn't necessarily capture everything that every one of us is talking about or thinking about in any moment. But I will do my best to paint the fullest picture of the healthcare and social assistance sector in Oregon, which has been growing and increasing in its importance, not only to the people who live here and who are served by it, but also to the economy. Switching over to the next slide. Thank you for doing that one too. I'm used to just always doing my own. First, I'm just going to set the broader context about what's been happening in the economy overall, in the labor market at least. So if we're looking, again, this is grounded. The report was published in July. It's grounded in annual data through 2024. So annually between 2023 and 2024, Oregon added essentially no jobs. I mean, this has been updated since then, and this picture has actually deteriorated a bit more since then, but the contours are about the same in that over the year we've seen, so from 2023 to 2024, it was about 6,000 jobs, which is the slowest growth that we've ever seen in a year that was not associated with a recession or immediately following one. The gains that we did have, highly concentrated in, this is private healthcare and social assistance. We'll get to the public part in a minute. At privately owned establishments was the bulk of the growth in between 2023 and 2024, and again has become even more exaggerated where as of this August, Oregon's actually lost jobs over the past year, about 18,000, and private healthcare and social assistance has grown by almost 12,000. Which means there's some other areas that aren't doing so hot. Manufacturing in particular, which is down by 8,500 jobs or more than 12% over the year. Construction is another one, and retail trade still. So a lot of the contours are still the same with those ones that are struggling most at the bottom, but the numbers have changed just a bit. Yes.
Can you define what a job is? Is it an unfilled position? Is it a filled position with a body in it?
These are jobs on employers' payrolls. So these are payroll jobs. But
so if you're just as an example, so if you're a hospital and you're hiring a bunch of travelers, but you fill that, then you fill those with people, it's going to show up not as a job, but then a job.
So we're going to get to that too.
Okay.
So if you have somebody that you're hiring from a temp agency to come in and fill some of the work that you're doing, that's captured in a different sector of the economy, which is actually under professional. Well, it's under administrative and waste services, very actually, like not intuitively named at all, right? But under administrative services falls temp helper employment services. And one of the things that we've done since 2020 is go in and look specifically at the temp help company. We'll talk about it in a minute.
Okay.
But there's a certain piece that is being fed there. It's grown over time. It's not nearly as high as it was during the peak usage in that 2022 period, but it's still elevated compared to before.
Yeah, because I guess my question was, how many of these were jobs that couldn't be filled during the pandemic and post-pandemic period by permanent workers that are then filled versus like new jobs?
So in 2023 to 2024, not so much.
Okay.
But we also happen to be one of like the 3 states in the country that run our own job vacancy survey. And so we know how many job vacancies there are that private employers report to us every quarter for jobs that aren't filled, but they're actually recruiting for. And no surprise at all, healthcare is usually the one that has the most job vacancies. And we'll talk about that too, because that's also growing prevalence over time. Thank you. Like huge preview. So on to the next slide. That's just kind of the broad context. Generally, Oregon's economy is struggling. The US as well, which I'll talk about here, also seeing dramatically slowed growth, more highly concentrated in private healthcare and social assistance. So within healthcare and social assistance, there are 4 major pieces or subsectors, as we call them. So the first one is ambulatory healthcare services, which I'm going to take a minute to explain. I know a lot of you have heard it before, but for anybody who's newer to this, that's also not intuitively named. It's like doctors, specialists, this is your dentist's office, chiropractors, things that you can walk or amble yourself in and out of. That's the top bar is what growth looks like between 23 and 24 for the US, and the blue one, or the darker bottom one, is what it looks like in Oregon. So there's that, hospitals, which makes sense. Again, it's just private hospitals for now. Nursing and residential care facilities, also pretty intuitive. Social assistance is things like community and food services. Again, this is private sector part. Child daycare services is in here. So a mix of things like that. The point that I'm trying to make here is that it's not just one part of healthcare that has been growing, it's all of them. And also that this isn't unique to Oregon. Again, we look pretty similar to what's going on with the US as well. Okay, next slide.
I'm struggling a little bit with what private means as.
That means
it's public, the.
So, like a public hospital would be OHSU. That falls under local government. A public hospital, like in rural counties, there are often locally owned public hospitals, right? More so than what you'll find in some of the metro areas. So, like my hospital, for those of you who remember one of the times that I came here and I like just like got my face ripped open like in an accident, like running. I went to Salem Hospital for that. That's privately owned. So that is a private hospital versus like the VA is a public hospital that would fall under federal government. That's a good question.
Thank you.
Yeah. The other point I wanted to make is that healthcare growth isn't unique to just the past couple of years, you know, or just in recent times. We've seen, with the exception of that lull period, which had its own unique characteristics, in 2021 and 2022, private healthcare and social assistance has been a consistently strong, growing, and increasingly large part of Oregon's economy. Between 2021 and 2024, which is as far back as I've got this data comparably, total employment on payrolls, non-farm payrolls, grew by 24%, and in healthcare and social assistance, it was 92%. Again, that's similar to the US. If you went back and looked at the same period of time, total employment grew by about, 20% versus almost 70% for healthcare and social assistance. So again, this isn't just something that's happening here. We're in this period of time where we're seeing aging demographics happening for the US. And as that happens, there has been a tendency to have more need for healthcare services with the aging population. Next slide. Again, just consistency. I went back to these 4 pieces of healthcare and social assistance that I was talking about to say it's not just one piece that has grown. The doctors and specialist offices is that top line that's grown quite a bit. And then below that is the social assistance piece, is the second one that's kind of swooping up. So those have seen the strongest growth, but we've seen all areas expanding, including hospitals and nursing and residential care facilities as well. Next slide. Now, public piece. There is not just private healthcare and social assistance in Oregon. There are government healthcare and social assistance jobs that are happening. And actually, it's almost to the tune of another 40,000 on top of the ones that I was talking about before. So overall, we're looking at like 300,000 jobs in this part of Oregon's economy. So that's somewhere around the vicinity of like 13–14% of all employment. So it's a large and important piece. Looking here, the mix is a little bit different, where it's government employment in healthcare and social assistance is more highly concentrated in hospitals and in the social assistance aspect than in the specialists and nursing and residential care, which just kind of makes sense if you think about, you know, I just said, what are the things that we're going to find in local government? It's going to be those local government hospitals, the VA hospital. That takes up the majority of what we're seeing in terms of public, and the social assistance piece also makes sense as well in terms of services that are provided for people, you know, emergency food, housing, the kind of things that human service agencies would do, that kind of stuff. Yeah, but so just not to count out the the public part, even though the private is what we have the most complete and, well, not the most up to date, most current, not complete, the most current information on. But I want to come back and make sure that we're capturing this piece because it's also important. Okay, next slide. Which was also previewed for us. Thank you, Becky, for the question, is that in addition to private healthcare and social assistance and the government piece, there's also some portion of employment that is happening in healthcare settings that is actually accounted for in a different part of the economy. So like I was talking about, there's also administrative services, and within that is temp health. What we did is we realized that there was an increasing trend, particularly if you see over here in the COVID period, immediately following the onset of COVID, it started ramping up and then has stayed higher since. Where, and we had conversations in this group about it, I've heard conversations in a lot of places about it, about traveling nurses, about people who are being brought in from temp agencies and providing healthcare services in hospital settings, in nursing and residential care facilities. So since we get all of the administrative records from every company that is required to pay unemployment insurance benefits, we can go through line by line in employment services and pick out the ones that we can tell from the name or that our team of regional economists who are stationed throughout the state know are providing specifically healthcare related temp services and track the employment at those companies over time. So that added piece is what we've done here. And as you can see, and this wasn't something that was really on our radar until the pandemic recession and afterwards, where there were unique strains on the healthcare system. So we started tracking it in the middle of 2020 and have kept up with it since. And you can see that it's gone from being, it's grown by about 4 times. So it's about 1,000 jobs in early mid 2020. It's currently averaging about 4,000, but was over 6,000 at one point. So in addition to all those other employment sources that I've been talking about or places that we find jobs, there's also healthcare that's happening in this part of the economy. It's less prevalent now than it was a few years ago, but it's certainly more prevalent than it was 5 years ago, and I would bet way more than 10 years ago. Okay.
Gail,
Yes.
do you, I'm sure the majority are nurses. Do you have the breakdown by occupation?
No, it's a really good question.
Yeah.
And I'll talk about some occupational stuff as we get down the line for the ones that are in the healthcare and social assistance sector. But for these kind of monthly numbers that we get when an employer provides these things to us, what they're required to give us is the name, identifying number, your SSN, your ITIN, like your identity, the amount of wages that you earned, and the number of hours that you worked. That is all they are required to give us, nothing else. There are some other data sources that we get that can help us, or that we partner with the Census Bureau to provide that can help us understand some of the demographics because they can cross-reference it with like your decennial census response or your American Community Survey response, which if you ever get is super helpful if you have questions like this for me to be able to answer. I got my own ACS last year and did it at night before I went to bed the same day, because that's how we get more of that richness in information. But just for this, that's all we did. Good question though. Next slide. We're going to start breaking into the wages and the occupations for the things that we can. So that was actually a good timely segue. When we look at the different healthcare settings that we get data for, again, those 4 major aspects, we can see, because when you just look at the top line, like healthcare and social assistance jobs and pay pretty high wages, but not everywhere and not all the time. So this breakdown looks at what those wages are like for each different setting. Hospitals is the highest. And this is broken out by public and private ownership. So you can see that it's regardless of whether it's a government hospital or a private hospital, hospitals have the highest average annual wages per job. It's over 100, well, it's over 100,000 in public and knocking on 100,000 in private. The next one is doctors and specialist offices, those dentists, those orthopedic surgeon offices, things like that. And then I pulled the temp health services one that we talked about too, and it's actually significantly lower, which I suspect has to do with the number of hours that they're working. Like, I don't think you're probably working full-time year round in that setting necessarily in Oregon, so it's much lower than some of the other ones, but I think that that's a factor of how that job function works versus whether like what their hourly pay is. I can't prove it, but that's my theory. And then you can see that down here, the nursing residential care facilities and the social assistance, so child daycare services, stuff like that, you can see how dramatically lower the pay is in those industries, which intuitively we all know, but it's just kind of nice to put numbers to it, right? When you look at the difference. And as we switch over to the next slide, the reason driving behind that is the mix of occupations that are in those different sectors, right? So if we look here, and like this is a little bit confusing, but hang with me, I'm going to try and make it make sense. Looking at each major area of healthcare and social assistance, the types and concentration of different occupations, very notably. Oh, and the next slide. Thank you. I know this is a lot of text, but hopefully you all can read it, and I'm happy to talk through any part of it. So I'm talking about those wages that I was just showing and the big differences in them really being driven by the difference in the mix of occupations that you're going to find in each one of those settings. So for example, in private hospitals, which is the highest paying of each of the subsectors we just looked at, 1 out of every 3 jobs in 2023 was classified as registered nurses. And the average annual wage for registered nurses was about $117,000 in 2023. So that's one of the big drivers of the wage that we're seeing in the hospitals. Obviously, there's also high paid doctors and other occupations, anesthesiologists, things like that as well. If we look at nursing and residential care facilities, also had one large occupation that accounted for a plurality of the jobs, and that would be home health and personal care aides. Again, 1 out of every 3 jobs, and the annual average wage there is $41,300. So looking at one big occupation in each of those and just demonstrating, as you look here, the mix of what's going on in those main occupations is what's driving those higher or lower wages. Does anybody have any questions or things you can ask about this? The occupational stuff usually becomes questions. Yes.
Kind of going to this graph and the previous graph or the previous information. I mean, I assume that one of the drivers here too is actually like unionization in these sectors. Like I assume that if you go back to the previous graph.
Go ahead.
That the social assistance, the reason public is so much higher than private is that the public home care workers are paid so much higher than the private home care workers. Like, did you look at any of those trends about like why the public and private are so much different?
I don't have any other thing to cross-reference with them. Like I don't get a flag or a thing that says like this job was affiliated with the union and this one wasn't.
Yeah. Well, I do. I think it's an interesting, but I mean, I think that like the differences in the sectors are interesting, but the differences between public and private are really interesting.
Yes.
And I assume almost across the board that some of that is driven by unionization. So I just think it's an interesting way to look at that information.
Yes, that, yeah, again, I don't have a specific marker for that to say one way or the other, but point duly noted. All right, back on occupation.
Yeah.
Yes.
Quick question.
Yes.
Did you have a question?
Oh, no, go ahead.
Okay.
Yeah.
On the wage differences, and I was gonna pull up the occupation profiles, but do you know off the top of your head if there are significant differences regionally in wages?
Yes, there are differences regionally in wages. The degree of them, I do not know, but that is something that we can look up. If we want to at the end here, we could pull up quality info.
Yeah, and it's
so-
in the occupation profiles that we just.
Yes, that we were looking at during the last
Yeah.
meeting. Yes.
Okay.
Yes, there's information
I'll
there.
pull that up.
Thank you. Yeah, if you go to the data tab and then Oregon wage information, it'll pull up those massive spreadsheets where you can take a look at it regionally and see the difference. Also, great plug for quality info. Thank you. Yeah, so the point that I'm trying to make here, so going back to what Melissa pointed out before, going back to the slide where she had the question, where we're looking at the differences are quite notable across different parts of healthcare and social assistance. And here then drilling down as to the why, one of the whys, or the most basic why, is that mix of what are the main occupations that are driving employment in those industries and what do those types of jobs pay. Next slide, please. Okay. This also came up early in our conversation, and I am grateful for it, is that what we've talked about so far is all the jobs that are on employers' payrolls, right? There are also some number of job openings at any given time that employers are actively trying to fill in Oregon. And for the first half of 2025, at any given time, it's about 51,000 job openings. One of the things, so in addition to becoming a larger share of overall employment, specifically as we're seeing these other sectors of the economy slow down, we're also seeing, again, this is just private, this is what we have for it. We're seeing private healthcare and social assistance become a more prominent piece of the overall hiring picture. So prior to the pandemic recession, so in the mid-late 2010s, pretty consistently every single quarter when we do the survey, we would be able to say that 1 out of 5 job openings was in private healthcare and social assistance. As of 2024, it was up to a third. Next. Again, looking at characteristics of the private healthcare and social assistance vacancies in Oregon. I want to duck after I say this, like it's not the most popular thing that I ever say, but I've said it here before, so most of you are ready for it, is that over and over and over and over again, ever since 2013, ever since we've done this survey, there have been 3 large occupations that always come to the top in terms of job vacancies. They are personal care aides, registered nurses, and nursing assistants. That does not take away from, even if they are much smaller, the importance of all of the other healthcare settings, all the other healthcare occupations that I know don't always get screamed up to the top of the list. But one of the things that's really interesting is that in 2024, we started to see this list diversify more. It was the first time I've seen it in a while, where now we're starting to see mental health counselors and some of the dental things, looking at preschool teachers, that's the social assistance piece. This is the first time that we've seen more diversity higher up in the list in all of the years that we've done this. So I thought that was a pretty interesting thing. And again, just to emphasize, and this is something that we really drill in on with employers and hiring and stuff like this, is that if you're looking at the average starting wage for any given job in Oregon, any given job, and 6 to 7 out of 10 of them require no education beyond high school, the average starting wage for a private sector job is $25.37. The thing that's critical about healthcare and social assistance is that a larger share of those jobs require some sort of education beyond high school, which I'm appreciative for when somebody is drawing my blood or stitching my face. Actually, the guy who did it, we had a conversation about what his job history was, because like, and has that time somehow, and I was honest, like, seriously, how much experience do you have? But so if you're looking at jobs that are requiring more education or having additional, even if they're legitimate, hurdles that need to be crossed for workers, and they are paying less than this, it might be more difficult to fill those vacancies. So, yeah.
That's a master's degree for $31 for a mental health counselor.
You said it, not. So, just, this is, I mean, like, I'm not, yeah.
It's crazy.
So, no, they don't really have super high, it's really interesting. Yeah, so this is something that I think I would urge you to take a little time to digest, look on, if you have it in your packets. I think this is where you get some really more gritty and interesting information here. And again, it's, it's employer reported. So this is from the employer's point of view. So when they're talking about, why is this job difficult to fill or something like that, the reason that they say it's hard to fill, if you went and asked that mental health counselor, why didn't you take that job? They might give you a different explanation than what the employer did, right? So just keeping in mind that all of that stuff is coming from the employer's point of view. Next slide, please. Okay. Let me catch up with myself here. Okay, talking about difficulty filling job vacancies, I knew I set myself up here. I went and looked at, so when our job vacancy survey that we have is relatively small, but over the course of a year, and especially in private healthcare and social assistance, which has such a large number of job vacancies, every once in a while, we get to drill down with just the biggest occupations. Again, it's not playing favorites, it's just what I'm giving you everything I have the data availability to do, which isn't everything, unfortunately. But we look at what are so in the job vacancy survey, we ask employers, what positions are you hiring for? How much does it pay? How many years of experience does it require? Blah, blah, blah. And then the very last line is this position difficult to fill? And if so, what's the primary reason? And it's an open-ended response. And it's amazing. We get such a wealth of information out of it. Then we have to kind of categorize all of these open responses into something. And they do fall into common themes. The largest of which in 2024 was a lack of qualified candidates, which is particularly notable for this sector because it's a mix of education, experience, it's not just they'll say like a knowledge, or we need somebody who understands how to provide care in a setting with people who are older or have a different set of needs or something like that. That would be a lack of qualified candidates as opposed to just like we need somebody with a certification. Yes, Jen, question?
I have a question. As you're talking about employer reported info and how they're responding, how they respond to in particular those questions that are asked, can you give me an idea of what's the response rate? Like how many employers are responding and providing this information? I'm just curious in terms of the number of.
So we're sending out about 16,000 surveys a year. So not a huge amount, but it is enough to be statistically valid. And we have about a 30% response rate from employers, which the corollary to what we're doing would be that, so nationally there's the job openings and labor turnover survey, and we have a better response rate than they do. So they've been struggling with it, and you'll see that they actually publish numbers for the states. Those are highly modeled, based on like what's happening with employment trends in our whole region. So they'll be largely influenced by California because it's much bigger than us. And the last time I looked, there were maybe 12 to 16 actual business responses in that kind of set versus this is 100% out of the employer's mouths.
Okay. Are you seeing any specific response rate trends by region or area, like a greater response rate in different?
Yeah, we struggle most in Portland. Big employers in Portland don't like to report.
Really?
Yeah. And the information's out there.
Yeah, okay.
It's a struggle, and so what we do when we're as we're talking about methods for it, we send out surveys. We'll do 3 mailings to each. So an employer gets put into the sample. We do it quarterly. You won't be in the sample more than 1 time a year. So we're trying to minimize the employer burden, make them not too mad at us because we're also then asking for your administrative records and everything else. And you don't need to hear from us every day. Although I'm fine with you. So we do 3 mailings with them. And then if we have, particularly like this is a great example, in the 4th quarter of the year, if we are not getting any answers from UPS and FedEx and Amazon during holiday package delivery season, we're calling them up and asking them what's going on. But we also do a random non-response follow-up in the areas where we're not getting up to that response rate that we need to feel quality about the results. So we're calling people on Portland.
Thanks for that context.
Yeah, absolutely. Okay, so looking at what they're saying, it's almost even, like about half of all the job vacancies in the state in 2024, employers are either saying there's just too few or no applicants, keeping in mind that unemployment's been on the rise over the past year, but was still about 4.2% a year ago, which is really low. Or lack of qualified candidates. So some knowledge, experience, care in a type of setting or something like that. That's about half of it. Then there's what we call unfavorable working conditions. Oh, we just want somebody like night on call 3 days a week. Well, if you can get a full-time day job and you've got kids, like maybe working night on call like 3 times a week isn't necessarily the greatest. Maybe that's unfavorable for you, right? But this is the employer even, so they're saying stuff like that. Or we get them in, and I did one of these with Oregon Business and Industry where it's like, oh, people just don't want to work. And then you actually pull out the specific quotes for manufacturing. They're like, these are people working in specific kinds of like very like clean suits where nothing can get dirty and you have to work in a refrigerated locker at 40 degrees for 12-hour shifts, driving a forklift. It's like kind of niche. So when you pull out some of those things, unfavorable working conditions can also be bad. Or it can be, working out in the forest and it's raining sideways and you're on a heavy steep grade and you've got to lift things that are 100 pounds. So that's the kind of stuff that falls in here. Low wages, this is the employer saying we pay too low of wages, not the worker. And then all other reasons. Some of them are miscellaneous, some of them are, like, there was a ranch in Eastern Oregon where they couldn't find anybody, because you had to have your own horse. That's like all other. So if you look at the differences coming back to healthcare, what's going on here, you can see that for private healthcare and social assistance, that lack of qualified candidates is a little bit more prevalent. And then when we start looking at the few occupations that we can, nurses, 3 out of 4, lack of qualified candidates. Whereas we're looking at personal care aides, it's just a lack of people applying. And if you look down here, what is this one, unfavorable or low wages? Unfavorable. So this is unfavorable working conditions. Kids are sweet. But so they're saying it's unfavorable working conditions, maybe it's part-time, when people want full-time work, that also falls in here. And then again with medical assistance. So you can see for any given occupation, the challenges that employers say that they're facing look different depending upon what they're hiring for.
Gail, remind me, you don't dive deeper. I'm very curious, and maybe consortium members can speak to this, but the high percentage for medical assistance that is not that is due to a lack of applicants. What might be driving that? Is it that they're pursuing other?
They're just saying like, hey, there's too few people, and one of the others also that and it goes back to your question earlier. It doesn't get captured in that lack of applicants, but one of the others can also be, they say like, they're just it's hard for us, like we have a really small labor market, or we're really isolated out in Joseph, Oregon. It's hard for us to find people. You know, like that could be a lack of applicants, or that could be a location issue. Location ends up in that all other reasons. But no, what I can pull out specific things that get bucketed in this way to try to give you a little bit more color underneath it. But no, they're saying there's too few. A lot of times, workers are doing that, or employers are doing this really fast, and just like there's a shortage. So to say there's a shortage of everything.
Yeah.
Yes.
Gail, good question. I'm assuming you're asking employers for this information. What would happen if you ask employees?
I'm sure that this would look a little bit different.
Yeah.
But that's the thing, is that what the thing I can survey for is the universe of employers that I have.
If you're trusting that they're being open and honest in terms of their data.
Yeah, they're usually pretty willing to
pretty good
chat. But yeah, that's the universe of what I can have, and make sure that it's a representative sample. Other than that, I just have to stand out on the street and be like, hi, would you like to talk to me? And that's not necessarily going to be effective or a representative sample, but that's the full universe that we get to work with, and make sure that I believe what I'm saying when I stand up here and say it to you is from employers. But yes, that's why I mentioned it's from the employer perspective. And, you know, we've pointed out some others and been like, you know, maybe employees would say unfavorable working conditions or some other things more often than the employer does. And they're like, people just aren't applying, which is an actual line that we get.
Yeah. Yeah.
I just want to lift up, I know you said this earlier, the fact that, you know, you're seeing other occupations, you know, in kind of the difficult to fill chart. And, you know, even though their numbers aren't large, the difficult to fill percentage for and oral health care, particularly for dental hygienists, is, you know, 76%. That's incredibly high. I mean, we also hear a lot about dental assistants. You know, a lot of turnover and difficult to fill there too. And then, you know, behavioral health crisis, you know, mental health counselors as well. So.
Yeah.
Is the chart before this, these are occupations that are most difficult to fill, or these are occupations?
They're the ones with the largest number of job vacancies at any given time in 2024. And like I said, it's not me playing favorites. It's just there's a certain cutoff where I can share more depth and feel good about it. And then there's a certain depth where we get down to it's like there's not enough responses here for you to feel good about saying this is representative. So it's just those occupations that have the largest number of vacancies at any given time, that are the largest number of hard to fill job vacancies, that I can then dive into what are their reasons.
That's really helpful, and for context for consortium members, remember we did the wage profiles for all occupations in this sector, but then we profiled those that were considered high skill, high wage, high demand. And so I've been just sort of cross-referencing, and for example, personal care aides don't show up in our profiles because they rarely require education beyond high school. So for our purposes, just that distinction, I think, is helpful, but by and large, the other healthcare occupations do show up in the profiles with the map of the different localities for wages for reference. But adding in the difficult to fill is really helpful.
Cool. I'm on slide 13. Thanks for bouncing out. I'm almost done, I promise. And I have 2 more to go. One more. Oh, anyway, sorry. Okay, so looking forward, we talked about, what we've seen in the past, what we're looking at right now. In the future, we do still expect to see private healthcare and social, or just this is all healthcare and social assistance, lead job growth. So our latest employment projections go through 2033. Again, full details by region, by industry, by occupation are available at qualityinfo.org. There's a projections tab that has a slider with interactive graphs, and then more spreadsheets than anybody but me would ever want to look at. And so I would urge anybody who's looking for deeper information specific to your area or your type of care setting of interest to look there. The top line is that healthcare has led job growth. We expect healthcare to continue to lead job growth. Overall employment is set to grow by 8% over that 10-year period. And with healthcare and social assistance, net gains are supposed to be about 13% or 37,000 jobs. That is just jobs from new or expanding businesses. If you look at the number of newly trained workers that will be needed to replace people who are leaving the labor force, retiring, some other reason, it's actually for healthcare and social assistance, almost 38,000 per year. So truly exponentially larger. So just underscoring the importance of that. And then within healthcare and social assistance, looking at the anticipated strongest growth being in that ambulatory care piece, but also stronger growth than the overall economy in all of the other subsectors as well. And again, just to underscore the point about new jobs, 1 out of every 5 new jobs in 2033 is expected to be in healthcare and social assistance. And again, this is government and private combined. Yes.
So I guess I'm wondering with this slide, I think it's really clear that the need for healthcare, the demand for healthcare services is increasing. And with the pandemic, we saw money coming into the system. We saw people deferring care, and now people are showing up for care. And a lot of money has come into the system. And now we're at a place in Oregon where there is less money in the system, where Medicaid and other funding streams, Medicaid program is at risk, very much at risk. And the federal government is going to have less money coming into Oregon for social care and health care. And demand's going to keep going up. And I think about things like, Oregon launched like the health related social needs benefit. We hired a bunch of community health workers and peers. And if Oregon decides that that's not a benefit in Oregon anymore, we have a bunch of workforce that's now unemployed, unfunded. And so I guess I wonder, like, how is Oregon, the employment department, like, I know that the need is going to go up, but if Oregon doesn't have money, what then? Because when I think back on the slides, it's not going to be people at the top. It's not going to be it's going to be the people at the bottom in social assistance that are going to be losing their jobs. It's going to be the people I think. So I guess I just wonder kind of how are we matching supply with demand when we're thinking about employment specifically?
Let me come back to that in just a minute. Because the next slide sets that up a little bit. You all have been the greatest grab because you're thinking about the very next thing that's about to come up. So if we go to the next one, and I will come back to your point as well. the first thing I'll say about this is that these were developed almost a year ago. The next round for 2024 to 2034 gets published in about 2.5 months and does reflect, the types of funding and continuation of things
Yeah.
a year ago looked a little bit different than they do now. That will probably be reflected in some of our expectations with a year's greater knowledge. And again, we're one of the only states that does these annually. There are maybe 5 states that do these annually. Usually you wouldn't get an update on that again for almost like 2.5 years after 2023 was over. So that will, I know it seems like, oh my gosh, that's a year ago, that's so long ago, but
No.
we need the full year's worth of information to see what's going
Yeah.
on. And then actually to go through the 480-ish industries or 380-ish industries that we do for the 9 different workforce areas and statewide, and then turn in applications takes some bit of time. But yeah, we are working on doing that updated with our latest round of knowledge. Not only would I say is funding something that's an issue, as we're seeing 2023, 2024, in each year, and I think it's actually notable that it's slowed down to flat. I think it speaks to overall economic conditions. We've seen that there's a record number of people who are no longer in Oregon's labor force because they're retired. That number is not beyond 800,000. So still probably need healthcare, but and healthcare and social assistance. Again, all ownerships, so public or private, has the largest number of workers, about 70,000 who are 55 or older. And maybe looking towards being not in the labor force due to retirement in this time horizon that we're talking about. One of the other things, and this comes from my colleague Jason Keaton, who many of you have met at prior meetings for this. So one of the things that we've looked at, and again, this doesn't paint a whole picture because Oregon does tend to import some of our healthcare workforce from Idaho or from people who graduate and other places, move here, get themselves established with whatever requirements it takes to work in our healthcare fields and then do that. Again, though, this trend is similar in those states as it is to us, is that, so replacing retiring workers and expanding the healthcare sector to meet the increasing demands of an aging population is possible with a sufficient pipeline, and money that funds it, right? Qualified workers in the coming years. However, since the 2010 academic year, overall enrollment has declined by 23% at Oregon public and private institutions offering certifications and degrees beyond high school. The number of institutions offering higher education has declined from 88 in that first 09-10 period to 73 as of the 2022-2023 academic year. The number of healthcare related degrees and certifications awarded has fared better than that overall trend, remaining at about 96% of that 2009-2010 level. So it's been about stable. But as I pointed out for the past longer than my allotted time, sorry, that's not kept up with increasing demand over that period. And so let me see the number. Yeah. Registered nursing enrollments in Oregon rose by 20%. Yet to the point again, we've seen the fast growth in the healthcare employment and the anticipated continuing replacement of healthcare workers in the coming years due to increased retirements. It does affect the future growth potential here. And with the growth potential, then taking that down to the human level, it is a detriment to the level of care that everybody needs being available to them. So yeah, it's a headwind on the economic side right now, but it's certainly something that creates a potential care limitation. And there's a full report related to this. Again, it's equality.org on publications. And at the end, there's a link in there where the Bureau of Labor Statistics looked at different occupations and their own forecast for those and saying like what level of like if they met the whole need, the employment would be here, but they expect it to be, and things range anywhere from, like full capacity down to 20 or 30%. So I would say that might be an interesting additional piece to check out and link to get to your point. Any other questions? Somebody have it online too. Yes, go ahead.
Go.
Okay.
Go.
The student enrollment number, it looks like that's coming from national databases. I'm just curious, but is it specific to Oregon? And is
Yes.
that enrollment in all
post-secondary healthcare degrees and credentials, or is it specific to?
Yes, and it also, but there's some things that don't get included. So number one, again, if you ever get a form and you need to report it, this is the kind of thing that comes back up and people say, well, that's missing. It has to get reported for us to be able to count it. And there's other stuff that doesn't necessarily get caught up in there. Like we've done a lot of chatting over the past couple years about, like non-traditional apprenticeships and things like that. That's not necessarily gonna be counted here either. You'd have to be, it's something that has to be required to be reported into the, I wish I could remember the acronym for iPads off the top of my head and I can't, I'm sorry. But into the iPad system to get counted here for us to be able to show it.
Okay. And do you know why you use that directly rather than HEC data?
I'll ask Jason. He and I usually do this as a tag team and that's why. Yes.
Just follow up on Cheryl's comment and question. So I guess this will impact eventually training, considering in terms of what field young people want to go into this coming year, the next couple of years. So I guess the data you're having come the next year or so, that would help the industry a lot in terms of just what training, what education people are going to get into. Because right now we're hearing from young people that what's happening to healthcare? Is there a job there in the future for me? Considering the climate, considering everything that's happening at the federal level and also the economy. So people are starting to question, are there going to be job cuts in healthcare the next 2 years? So now they're thinking of other careers. So I guess we definitely want the information, by the way, from you guys, because that'll help a lot of the industry, but also people to make decisions in terms of what they want to do or not do eventually.
And yes, and that's actually the purpose of why we do long-term employment projections is to help training providers prioritize within the constraints of funds that they have, what things are missing, what needs to be filled in, what, when there's only so much money to go around, if there are, 20, 200 or endless needs, but we can fund these 10. This is meant to help guide the conversation. It sets the table for the kinds of conversations about prioritizing those. And, I have 2 kids, they're 12 and 10. And my daughter wants to be an anesthesiologist because she looked at the money number. And she figured out when she cut her own hand accidentally a couple months ago that the blood and guts part wasn't for her. But like when I talk to people and say, if it is the kind of thing that you're interested in or that you can handle, I could not. Even in a time when we are seeing job cuts happening in other places, it is an industry where there is continued hiring and expansion going on, even if slower than it maybe needs to be to meet everybody's needs, it's still there. And it's one of those things that, yes, you might have to get a different certification or get it trued up with the state that you're in or the part of the world that you're in. But there is kind of a universal ongoing need for healthcare everywhere. And it is one of those industries, and this is like just my opinion as a human, not necessarily like representing the employment department, that it is one of those long-term growing industries that also does have career ladder capacity in it, and is something that is, there are tons of follow your heart, do the thing that you want, but it's something that does seem to have a greater amount of long-term security for folks if it's something that you're into.
I really appreciate this slide because it starts to look at that disconnect and the gaps between workforce demand and talent supply. And as we've talked about diving into that on an occupation by occupation basis, it can give us a picture of the workforce demand through a different lens.
And so one of the things people really love to do is take the one number of like growth and then take this number and subtract the 2 and say that's the difference, and that is not sufficient. Again, because there are pieces, like you said, with occupations looking at supply and stuff. There is a way through Census Bureau 5-year American Community Survey data, but it's a 5-year average, and geez, what's changed in healthcare in the last 5 years? Where you can look at occupation by occupation, what's the net gain? Typically it's been a gain, might be a little different in the past 5 years as well. By occupation in Oregon of folks working in this type of occupation. So there's that piece that can be looked at. It takes a lot of time and a lot of effort and some great partnership with Florida State University. So there's that piece to add to it. And then there's people who retire and then unretire. There's that piece that happens depending on economic conditions, other things that are going on too. Yeah, so there's other nuanced pieces that it's more than just taking the one and subtracting it from the other.
Yeah. I think we did also have some questions online.
Oh, yeah, sorry, I'm like, nobody else is gonna be able to respond to me. You can talk to me during break if you want to. And I can answer the ones online during break too, if you want.
Nope, you're okay.
Okay.
We just have kind of one question here, and I'll take us back a couple of slides. It's related to, I believe this slide where they talk about lack of qualified candidates. Is there a definition for this term, and is it essentially data that is influenced by employer bias?
Yes, to the last part. As we talked about, Marin had a great question, somebody else did too on that. So yes, it is from the employer's point of view, because the employer is the one that we have the capacity to be able to ask. And then a lack of qualified candidates. I'm trying to think of a great healthcare one, but I'm struggling with it, because the one that's stuck in my head right now is, truck drivers. Truck drivers is an occupation that, that typically rises to the top in terms of the number of job vacancies year after year. And some people will say, you know, like, we don't just need somebody to drive a truck, we need somebody who understands how to drive a log truck on difficult terrain without wrecking it. That's, so you need to have some sort of credential for that, some sort of CDL, so some sort of attainment piece beyond just hopping in a truck and driving it, right? And it can't just be any truck, it's one that has specific needs with different types of terrain. So that would be a lack of qualified candidates, because you need to have that mix of knowledge and experience with a specific type of driving your truck. And the one that I gave earlier was nursing and residential care facilities, right? So it's like, okay, we need a nursing assistant, but we also need that nursing assistant with the credential that you have to be a nursing assistant to have the, you know, the bedside manner or the capacity to be able to do this in a specific type of population with not just necessarily the same needs as the general public. So that would be another one too. That would be a mix of knowledge, experience, skills that are happening specific to one type of occupation.
Thank you.
Yeah.
All right, other questions for Gail?
Right, thanks everyone.
Thank you. All right, I believe Sarah Means is with us online. And we will get her on the screen for an update. There she is.
Hi, I lost you just for a minute while I joined as a panelist. Are you ready for me?
We are, we can see you and hear you.
Wonderful. Well, I can't see you. It looks like a table up there, but I'm gonna trust that you're all in the room. Hi, everybody. I'm just gonna introduce myself. Sarah Means. I'm the governor's workforce higher ed and economic development advisor. I've been in this role a few months now, and you're accustomed to seeing Sarah Foster. I've taken on a portion of her portfolio as she's moved on to bigger and better things, and we're all so happy for her about that. I don't have all of her portfolio, but a portion of it that I do have is work related to the Behavioral Health Talent Council. And so I wanted to make sure to provide you all with an update on that today. I'm sorry I can't be there in person. I would have loved to have had the ability to drive out to Tillamook today and enjoy the Oregon coast, but I'm stuck in Salem. So apologies for not being there in person. So I just want to jump in real quick and give you an update and just to level set. I think everybody probably has a high level understanding of what the Behavioral Health Talent Council is, but in case you don't, the governor established this council really to formulate new strategies to address Oregon's behavioral health workforce crisis. The council is chaired by the First Lady and will develop a recommended workforce action plan. And we're going to do that by January 31st of 2026. So we are working very fast. The recommendations that you will see by the end of January are really coming out of the behavioral health talent assessment that was commissioned by the HEC. And what I will say is that this council is a really diverse council. There's 22 members, I believe. that really bring expert information and guidance from diverse backgrounds in the field, healthcare administrators, licensing authorities, educational institutions, and so on. So it's a really great group. This group has broken into 3 distinct committees. There's a recruitment retention, excuse me, committee. There's a licensing committee, and there is the education and training committee, which Jennifer, Shawley, and I work most closely on. And so we're in the really in the a period of time where the committees, the subcommittees that I referenced, are doing an insane amount of work, frankly, developing action plans based on the recommendations that were assigned to the committees. And this is where I really need to pause and give a huge, huge shout out to Shawley and all of the work that she's doing, in particular. Jennifer as well. I don't want to suggest that Jennifer's not, because she is. But Shawley, she is just an incredible partner in this work. She is drafting action plans. I don't remember how many action plans we have, but I don't, 8 or 10 or so. And they are addressing multiple recommendations within the action plans. I'm telling you, these action plans are nearly 15, 16 pages long. And she's developing them over a period of a week or so to make sure that they get to the subcommittees in a timely manner so that the subcommittee members can then review and provide feedback. And doing all of this while also keeping us, on task and providing sort of content expertise as well. So the staff at the HEC, Jennifer and Shawley in particular, have just been wonderful in moving this forward. Gold stars around. And I will say, because I'm not competitive at all, but we are, our committee is sort of paving the way. I don't know if that's good or bad, but we are paving the way for the other committees and developing the templates for the action plans. So all of that to say, we are in the middle of this sort of action plan development work for the next month and a half or so. I think we have to, maybe 2 months, we have to finish up by about mid-November so that all of that work can then be reviewed and adopted by the committee or the council, excuse me, and be ready for that January 31st deadline. So I might just stop there and see if there are any questions. And I know Jennifer, I think Shawley is Jennifer and Shawley both there?
We are both here. Thank you.
Wonderful. They are the content experts. I am doing nothing other than making sure they get what they need out of our office. But happy to answer any questions of the group if there are any as we look at moving this forward.
Yeah, Sarah, thanks for being with us today. In addition, I know you were unable to join us, but the executive leadership team for the consortium met with the First Lady recently and talked a little bit about roles and responsibilities and how the consortium might be able to support or complement the work of the Talent Council going forward. So I don't know if you all want to speak a little bit to that.
No, it was a great meeting. I mean, I personally was asking more about if the council was talking about the building of a culture and need of therapists in this field. And the First Lady definitely stated that they're making a commitment to talk about this issue, making sure that there are less barriers, less obstacles for people to get certified as counselors. But definitely our concern was that people are waiting 12 months to see a Spanish-speaking therapist for the state of Oregon, and that's really detrimental to the health of our community members. So they definitely made a commitment toward that. And so I'm glad to hear that from the First Lady, that they're really talking about that within the council.
Yeah, and I'll add for me, and this is Adrian Bennings with Portland Community College. It was insightful to hear the First Lady's thoughts on how that work will evolve as they move forward. And one important question or key part of the discussion that came up was, once the work of the council is complete, how can we be helpful in the sustainability as well as the accountability of the work as we move forward? And that's still left to be, I guess, fully fleshed out. But we did present, I think we were unified in terms of of just how can we be leveraged in this group to continue and advance the work. And I think what I got from the First Lady was that she was open and receptive to exploring that further. So that was helpful to see how we could continue to be a part of that work while the council's formulating recommendations, once the recommendations are formed, and then continuing that work beyond that time frame as well.
I would just add that taking the talent assessment and then trying to operationalize some of the recommendations in the talent assessment may provide a model and a pathway for other types of occupations if it's successful. So I'm interested in how in watching that work play out and seeing if there's a way to apply those recommendations to other occupations.
Yeah, I don't have much to add after all of those comments, but I do think overall, I do think it could, there's a lot of work being done, and I think there's a really big opportunity, especially as if there's going to be a significant investment of resources, to think about what are the systems of transparency and accountability, and getting, I think, outside some of the employers to engage in that process in a meaningful way, owning the role that the government plays in actually funding that and the role they play in order to come up with a joint plan can then actually be followed up on. And I think that was a part that was really, I learned a lot from.
Great. Well, because I'm sure you all have the talent assessment adopted to memory from Hubbard. There were about 65 recommendations in the talent assessment, and the Talent Council has taken that and prioritized those recommendations, assigned them. Neelam's supporting some of the work of the recruitment and retention subcommittee. We're working with the education and training pathways subcommittee. There's also a licensing and credentialing subcommittee, and those action plans, again, we have in education and training, I think we have about 37 of the recommendations, and we have coalesced those into about 10 action plans. So it's a significant body of work. I think recruitment and retention is probably similar, around 20 to 25 recommendations, and coalescing those into action plans. So one of the things that we talked about was how can this consortium help to advance some of the priorities where we have influence in post-secondary education and training, and then maybe where can we be an ongoing accountability partner tracking the work that's being implemented as an outcome of this work. So
and Jennifer, I might just add to that, as much as we would like those, what was it, 30, or I can't remember how many recommendations in total, but all of these recommendations to fit neatly into our subcommittee boxes, right? That's not actually true in all instances. And so these subcommittees are also, there's an expectation and a really, frankly, a need for the subcommittees to coordinate amongst each other as well on these action plans. So for instance, we have an action plan that frankly feels a little bit more like it needs to be with licensing and credentialing, but it was assigned to us. So we're going to be good partners here and work on that plan. But licensing and credentialing will need to take a look at that action plan and provide feedback as well, and vice versa. There's some recommendations that'll need to come to the education and training committee as well. So just for folks to know, as much as we like these things to be black and white and fit into their boxes, they don't, and we're addressing for that within the subcommittee structure.
Great. Well, in terms of timeline, this consortium, this is our Q4 meeting, even though it's September. So we won't meet again until January. So I anticipate that at that January meeting, which is virtual, we'll be able to get an update on that work, and it will be nearing sort of final recommendations in action planning coming to the Talent Council. So that timing should work well. Ironically, it was this past January at our fully virtual meeting when we had the presentation of the talent assessment. So it's kind of remarkable how much work has happened with that work product in just a year's period of time. So Sarah, thank you so much for being with us. Does anybody else have questions for Sarah? If not, we appreciate your time. Thank you.
Thanks, and appreciate you letting me pop in and pop out. Again, apologies, I can't be there in person. One of these days I will make a point to be there in person, but thanks everybody for the work that you're doing and the partnership, particularly on this Behavioral Health Talent Council work. So have fun in Tillamook today.
Thank you. So with that, we are right on time. We're gonna transition to our employer panel. So if you need to refill your coffee while panelists are making their way up front, please do so. There's muffins, etc. as well.
I am Becky Holberg, as we did introductions, you heard who I am. I run the Hospital Association, and so I'm really happy to be here with two of our representatives from two of our member hospitals. There are 3 hospitals in this region. One here in Tillamook, and you'll meet to I think the CEO of that hospital will be on a panel a little bit later today. There's a hospital in Astoria, Columbia Memorial, and then a hospital in Seaside, Providence Seaside. And so 3 great little hospitals in this corner of the state doing really important work. And we're going to talk a little bit about what's important about that work and what's challenging about that work. So before we jump into those big questions, maybe just quick introductions, like who you are, what you do in your hospital, just a little bit about your organization and your role.
My name is Jeanette Shecker. I am the Director of Operations at Columbia Memorial Hospital. I oversee the medical group, the CMH OHSU medical group with our partnership with OHSU. My background, my doctorate's in physical therapy, so that's how I ended up at CMH 18 plus years ago, and have found my way into leadership and love it. A little bit about CMH, we are a critical access hospital. We are one of, I think we're now down to 4 independent hospitals left in the state of Oregon, which is pretty unusual. But that's kind of about us. We are in the middle of a really, really big expansion project. So if you visit our campus, you'll do a little bit of walking more than usual because we are under construction, but that means we're growing, which is exciting.
And for those of you not in the hospital world, which is probably most of you, a critical access hospital is a designation, a federal designation that means you have 25 beds or less. And that's important from a payment perspective because your Medicare payment is cost-based if you're 25 beds or less, which makes a big difference. Because if you're 25 beds or more, Medicare does not cover generally the cost of care. So they're all 3 of the hospitals in this region are critical access hospitals, even though there's a big difference between a big critical access hospital and a big provider and a small one. Okay, go ahead.
I'm Shelby Gosser. I am a nurse educator for Providence Seaside. I am responsible for much of the training and recruitment for mostly nursing, but many other healthcare occupations. And we're also critical access hospitals, and we are tied to also the Providence healthcare system, which is.
My name is Annalie Green. I'm an associate nurse manager. In my everyday role, I assist our chief executive officer, Rebecca Copeland, as well as our chief nursing officer, Jason Morgan. I've been with the organization for 15 years, actually 14 years in November. We are, prior to my role of taking this role 3 years ago, I was a surgical services nurse for 11 years as acting charge nurse in that as well.
All right. So let's talk a little bit about healthcare on the North Coast. Like you all you're providing services in this region. What's unique? What do you think is unique? I'll give you kind of a choice. Like what's unique or what's challenging about providing services here on the North Coast? And we'll start with you, and then after that, I'll alternate. Yeah.
I mean, the North Coast is unique in that the people who live here, I think, are unique. And I don't think it's different between someone like Seaside and Astoria. It takes a special type of person to live on the coast. There is not a Target around the corner. There is not. So it takes a little bit different type of person to live there. But I think what that means is it's a really resilient group of people who have probably spent a good portion of their life that maybe didn't seek healthcare. And so
not only do we have issues with access to primary care because we need enough providers, but we have issues that we have people who have kind of neglected their health for a good portion of their life. So when they do show up, they tend to be train wrecks. And so there's a lot to piece out and take care of these patients. So you see people that have just kind of done without healthcare for a good portion of their life. Then you add to that maybe the need for specialty care. And I think we're lucky at CMH because you talked about like the difference between a big and a little critical access hospital. We are kind of that critical access hospital on steroids. We have many, many specialties that you don't normally see associated with a critical access hospital so that we can provide a lot of that care in our region. But there are still things that people are going to need to go to the city for. And you see a population where transportation can be a challenge and a lot of the social determinants of health that step in and really impact people's care.
So I'll jump in here before we move to Shelby, because just an example I know to kind of like personalize the importance of services in these types of communities. Tillamook, for a period of time, about 6 months, did not have an outpatient dialysis provider. You all probably know this very well, for some regulatory reasons and other things. There's a story there that I won't go into. But they were working to try to bring the service back and it just took a really long time. In the meantime, you had elderly, frail people on dialysis driving across the mountains in the winter 3 times a week to get outpatient dialysis. That is the difference between having a service in the community and not having a service in the community. So when you talk about like an healthy, population that shows up and healthy, the ability of those folks to get care in the community really matters, because otherwise it's a long way for a population that might have transportation issues or health issues that even affect on the hearts. Shelby.
I definitely agree with everything you just said. Something from the recruitment side that we have found to be very challenging is maybe we could get a great caregiver who wants to come in whatever role, and they come and then they find it's not a great fit for their family and the community resources that are there. Maybe it just wasn't the lifestyle they were interested in for their partner or their children, and so that's been a great challenge. And so we have tried very hard to recruit as locally as possible, but then we also have just the infrastructure of what's available for programs. And that's something we've learned over and over too, that it's been really important to invest as much as we can, supporting our caregivers to move on to higher education.
They pretty much answered the question already, but to add on, we saw a big gap in care for us. And the challenge was if there was car accidents out on 26 and then the gap between Tillamook and Astoria, there was no area for trauma. So one area we had to add on for us, which we just now achieved our trauma level 4 designation, was adding that trauma. So that way, if an accident happened on 26, that they didn't have to bypass us and go all the way to CMH or down to Tillamook or into Portland. We were able to care for those and stabilize and ship. So that was a big, huge challenge for us. But now we achieved our trauma level 4 designation last month. So.
Okay, let's talk about workforce. And Shelby, I'm going to start with you. So what are your greatest, well, this is a big question. Can you write them? What are your greatest workforce needs and challenges? Like, where do you find them to be the challenges?
I would say right off the top of the head is definitely occupational therapy. Within that window right now, we've actually dedicated our local foundation, $1 million to go to some recruitment, especially for that. And then of course, MAs. I think we've talked about that. MAs have been a large challenge, but Brett, it's been all things under occupational therapy has been very challenging to find, especially that they want to stay.
Emily, what about you? What do you think?
Our second biggest gap is diagnostic imaging. That remains where most of our travelers are, our temporary workers are at. I would say probably roughly 80% of that department currently is travelers.
So tell the group, like, what certification or skill are you looking for when you're like recruiting for that role?
So, diagnostic imaging is the, umbrella over it, so we're looking for X-ray techs, CT techs, mammography, ultrasound, all of those. Imaging, like if you broke your bone or if you, CT, MRI, those are the biggest areas because not a lot of students go into them.
And I think that's an interesting point to bring up, because we talk a lot about RNs and CNAs, but we don't always talk about techs.
Exactly.
And the role that they play. But if 80% of your department is travelers, that's a pretty high statistic.
And that's not unique just to us in Seaside. I'm sure CMH and our sister hospitals in the coast are experiencing that as well. But if you even go into Portland, even the Portland service area struggles recruiting in that area.
And I'm sorry, go ahead.
It's just an overall not a big area where high school students or even the population really knows about, because when you think of healthcare, you think of doctor and you think of nurses. You don't think about the lab techs, you don't think about your x-ray techs. If you think about it, when you go into the emergency room for something, more than likely you're gonna get some sort of imaging. You're gonna see, get an x-ray, you're gonna get a CT, you're gonna get something to help diagnose. Where those fields we rely on those as nurses and physicians to help diagnose and treat patients.
And what is the education, like what kind of education certification?
Most of them are 2-year associate degree.
So when we talk about career pathways in the healthcare field, I think this tech pathway is a really interesting one, because it's a 2-year degree with good job prospects and then opportunities to create a career out of that.
You guys were talking about job cuts and people worried about job cuts earlier. That is not an area that will be eliminated, because if you can't source that, it has to be done by humans taking that. So,
yeah. Okay, I'm gonna start with you for the next question, which is just, when you think about these shortages, these recruitment challenges, like what strategies do you think have been successful in this part of the state in terms of recruiting your organization and recruiting and retaining the workforce?
In particular, I think diagnostic imaging, it's an area where we're still struggling in, to be honest. But we also, other allied health areas, with respiratory therapy, we were primarily travelers for many, many years. But we got solid leadership in there, and we were able to convert every single traveler we had the last 2 years to stay on the North Coast. Why, I have no idea, but I can't give you an answer for that one. But so we were able to eliminate travelers under there, but I don't really.
I think a huge win was we started offering tuition reimbursement for our caregivers for any employment status. And so a big recruitment is we would offer per diem positions, which is kind of a bare minimum they need to work. And while they're eligible for healthcare benefits, they're eligible for the tuition reimbursements, and we went to the max amount the federal government's able to allow us for exchange of taxation. And that has been a huge recruitment tool that we've been able to successfully with community colleges, especially in certification programs.
Retention
This is my favorite strategy.
Okay, take as long as you want. Okay.
Hi, you can tell me shut up. So we struggled with a lot of all of these same areas, and we figured out we have to get creative, right? We have to do things a little bit different. We are really, really fortunate in Astoria to have a community college right there. And so our partnership with that community college has been huge. Things like, luckily they have a medical assistant program there. So every single year we pay for 8 students to completely go through their program tuition free and do scholarships for that. That was huge, but then when we started to realize on the medical assistant side was they only graduate in June, and our need is not just in June, our need pops up year round. So we started to think, well, what could we do inside the organization to train our own MAs? And there's a program that is held in Southern Oregon that basically is an MA internship program. So we thought, well, this seems like a great route. We could kind of partner with that. but they had to identify applicants for you, and they were in Southern Oregon, so they didn't identify a lot of applicants on the North Coast. So then we thought, well, we could do this on our own. And so we did. We found a curriculum for an MA internship program. We decided we would post these as employed positions, because what we saw as one of the barriers for an MA to go to school was that they had to quit whatever job they were working. It was a full-time day program. And so unless they were working nights or weekends, and most people couldn't live without their wage. So we could offer an internship that didn't pay the full rate of a regular MA, but was kind of a stepping stone. And what we figured out was we could take an individual who had an interest in becoming a medical assistant, and we could actually create a certified medical assistant in less than 6 months with this program. Some of them, depending on the actual applicant, these interns have done it in like 3 months, they've gotten it done. So being able to be creative and train our own. We also looked at what we deemed to be a medical assistant. We were pretty tight on what the job qualifications had to be. They had to have this certification or they had to have that. Well, we live in a military community, and a lot of people, especially in like say the Coast Guard, can become an MA without a certification. That was kind of on the job training that happened through the government. And so we didn't recognize that as an MA, and they didn't qualify for our jobs. So we had to open up our job description of what an MA was. We started to take EMTs and paramedics as MAs because they had training that was really comparable. And so maybe there's a few things we had to tweak on there, but opening up that job description. So for MAs, we got really creative and went a bunch of different routes, and it's working. What we had for probably 30 MA openings in 2020, 2021, I probably have 4 or 5 MA openings total right now, and usually those are coming because somebody's gone away to school or their Coast Guard and they moved away or something like that. We had similar situations with pharmacy techs. We couldn't hire pharmacy techs. Well, why couldn't we train those on the job? So we developed an on-the-job training for pharmacy techs. Nurses, we did the same sort of thing with scholarship program for nurses, making sure that we had scholarships available for that. But we also figured out we needed to partner with the community college to sustain their nursing program. They needed help funding it. And so between Providence and CMH, money went toward the community college to make sure that program stayed in place. And then we had baby nurses that came out of school and they maybe didn't stay very long because the world was kind of their oyster and there were different things they could do. So putting in a nurse residency program to support those nurses and make sure they got on the right track and that they wanted to stay. They felt valued in the organization and they wanted to stay with the organization. So it's been a long road to keep looking at different other areas, but it's come with a lot of partnerships.
Yeah, which leads into the next question perfectly, which is about partnerships. And I think it's interesting here because we've got a variety of different partnerships. There's the community college partnership. You're as an independent hospital, your partnership with OHSU, you're part of the system. So just talk about like the importance of partnerships in addressing your workforce needs. And I'm going to start with you. Sorry, you said it, but you know, there's three of you, so this is how I'm going to.
So I think that, yeah, there's different, the community college has been huge when it comes to making sure we can have MAs, we can have nurses, and we can keep that going. I think our partnership with Providence is another big one. When you're on the coast like this, you don't look at that hospital down the street as your competitor, but you really need their resources to support each other. So making sure that you have good relationships with those partner hospitals has been probably a really important one. And then we're really fortunate to have our partnership with OHSU, where I think that has helped us a lot, has come with the recruitment of providers. And there's whole nother area of shortage that we experience, primary care, OBGYNs. And prior to our partnership with OHSU, we couldn't get a resident trained ED doc. Like that was really, really hard to find people that had that special certification. And so as we partnered with OHSU, the recruitment efforts that we were able to pull from what they could pull and what we could work together. And the fact that quite honestly, a provider could put on their resume that they were also an OHSU employee looked pretty good. And some people are, attracted to that. So those have been really, really big partnerships. I think the community college one continues. Right now, they have more MA students than they have ever had starting this program. They have 25 students. They have not had a full class in years. And so how are we partnering with them? Well, they don't have the staff to be able to teach 25 students. So we're using our MA trainer to help supplement some of the training that they're doing. And so just finding those partnerships and ways that you can kind of help each other out.
It's great. Shelby, partnerships.
Yep, I mean, Exactly. I think we're probably partnering with a lot of the same people. Also, I was thinking top of my head, our partnership with House of Behavioral Health. We've had to rely so heavily on kind of collating community resources as much as possible, just to kind of navigate all the healthcare challenges to help try to share resources, help get people to the right positions. It's really, it's one big small group that we're all using the same resources.
I don't really have much more to add, but one partnership that we're in development with is our local school district as we look at opportunities to develop CTE programs and do that in the future. That's, just in the talks right now, but developing those pipelines to start capturing those high school students so we continue to grow our own and help them stay in the community and use our partnership with our college and CMH to really develop those positions, hopefully capture those tech positions a little bit more in allied health. So.
Which kind of does lead into the next question, so you can elaborate on it, or I can move to Shelby, but it is sort of the challenges and opportunities of like connecting people to these jobs, like this training aspect, but how do you connect them in the first place to healthcare careers? And is that, we talked about the CTL elements of reaching into the high schools. There's that, there's adult learners, so feel free to expand on that if you want to, or pass it to Shelby, but how are you thinking about connecting people to the opportunities that these careers create?
One of the ways we do connect is at our local job fairs. The community college, Plattsburgh Community College, has a very robust job fair every year. And every local area, CMH and us, we are there sharing about those job opportunities, sharing about that, sharing about different areas of healthcare.
No, I think what we're excited about is, and I know CMH has a wonderful partnership with the Asbury School District, is trying to really partner locally with our Seaside School District as much as possible, try to get people in earlier and then build some high school credits for them as well. So that's another thing that we're trying to work as quickly as we can.
I think, so we supply the instructor for Asbury High School's health careers program. And so that creates connection. But I'll tell you, as we talked about recruiting for some of those more entry-level jobs, the kids that are attending a health careers class are not interested in becoming, historically, they're not interested in becoming a CNA. They're not, they're there because they want to go to med school. I mean, I took that class in high school because I wanted to be a PT, and that's why I was there. And so how do you target the kids that don't know what they want to do? Because those are the kids that these opportunities are just absolutely right for. And so, working with outside of the health careers class with the counselors, and how do you get in touch with some of these kids who don't know what they want to do? And maybe, the MA internship is a really awesome example. You don't need to go to a college program to step into this program. If you're somebody that is studious and is the right fit for this type of career, then that's who we want. So what we've been really fortunate is that position, I think we're probably the most proud of, is we opened up those internships. We thought, well, we'll start small, we'll hire 2 of them and make this really small cohort. And we have 25 applicants for it, which is amazing as an opportunity. So how do you get it in front of not the kids at the health careers class, because they really do have their eye on a different prize, of the kids that don't know what they want to do. Yeah. We are working with the community college. They reached out just recently asking, what certificate programs do you need? Where's the gap? And so it was the things like the lab techs, the imaging techs. And while that may not necessarily be something that Classic Community College can provide as a radiology tech or things like that, but making those connections so that we can offer those things as well.
All right, last question, and we'll have a little bit of time for Q&A. So, as employers, I guess I'll give you kind of 2 ways to answer this question. What's your role as an employer in building these partnerships? And then what help do you need? What's the role of the state, groups like this? What support do you need as employers to continue to grow this work? I don't want to start with that. I don't want to start with that.
That's a hard question.
I guess, we'll just wrap up this way then. Where do you see these like you started some partnerships, you've built some partnerships. Like, what's your aspiration? Like, what would you say what would you want to look differently in 10 years based on what? Today? I'm asking hard questions. Anything on it softball? Jennifer?
Well, I was gonna say, I just put my rural hat on. I actually love that the question about partnerships stumped you because I think it's evident that partnerships are sort of how you go about doing the work in rural communities. So I'll just add that. I think it emphasizes that it's like, well, that's just how we do things, and you can see that in the partnerships that you're sharing with us. I do have questions, but
Okay, let's move to questions.
Marin has one.
Yeah.
Sure, great work, by the way. How does housing affected your recruitment retention?
That's one of the biggest
Challenges?
So I was an interim manager for diagnostic imaging for 9 months. And I had probably about 2 or 3 applicants, but they ended up turning away and taking positions, I think, within the Portland service area because there was a lack of affordable housing. And it really, not even just affordable housing, because that is probably one of the biggest challenges, and not just for diagnostic imaging, but for all areas of the hospital that continues, whether you are coming in to work as a CNA or you're coming in to work as a physician, trying to find just housing in general is one of our biggest recruitment issues.
We have that same issue. We've had people ready to start a job and then they can't find a place to live. When it comes to providers, we will supplement, we will find housing for them and put them in, we have access, we have our own housing that we can put them in for a time until they can find their own, but that gets really, really challenging. I think we've ruined some of these like nurses that are traveling nurses because their housing is paid for, right? Your agency is paying for your housing. So now when you decide you want to step out of that and maybe take an employee position, you have to pay for your own housing like that. And so now they're asking, well, not only do I want a wage, I want my housing, and so they're looking for that much more money because they haven't paid for their housing in so much time. So we're ruining people when it comes to that sometimes.
And I guess, what are your plans to address that? Are you guys talking or finding, or how do you address that with your community?
Yeah, in Clatsop County, the CCO put together kind of a housing sort of, they took the old Red Lion and Seaside and turned it into housing. And so that was meant to be like kind of multi-use housing. That's 70% for healthcare. But have you guys put anybody in there? I don't know that we have. Okay. I don't think we can put anybody in there for housing. And again, I don't know that it's meant to be a long-term solution by any means. But here's a place that you can go until you can find something.
They're basically studio apartments.
Thank you.
It's a challenge though, for sure.
Yeah, because the other reality too is caregivers we don't have a really robust public transit system. So they have to be pretty close to where they're at, which is also desirable for most locations, honestly. So there's a high premium to compete. And then it's much different summer versus any other time of the year.
And then if you add on the call requirements for some of the positions, you have to live within a 30-minute window. So that way, like Astoria for Seaside in the summertime is a little too far. And so you have this very short amount of space that you can find housing in. And so trying to work around that, so.
Question. Similar to Marin's question, we know childcare is a huge problem statewide and especially on the coast. Are there creative programs or solutions that you're working on to help address childcare for some of your employees? Is that still an issue? It's been an issue. Is it still an issue or is it resolved?
It's slightly improved. I currently have a toddler, so it's something I very much feel. Our Providence has partnered with Sunset Empire, our local park and recreation district. They have increased childcare greatly there. They have moved into our old middle school building. They have purchased it. And they've greatly expanded their child program there. They brought in an infant program and toddler program. So they now can have 8 infants and toddlers, and so that has created more spots. Also, there's been more daycares and childcare centers within the area that have developed over the last few years. During COVID, most of them closed and never opened, so we were in a childcare desert for a very long time. I want to say 3 or 4 of our big centers closed, and I don't think there was really any childcare for a good few years. So that Providence continues to partner with the local areas and provide money and grants and within that to help increase the childcare in the area.
Go ahead, Rob.
And this question maybe to Becky or anybody, but I'm a little curious, that was a great presentation on from Gail this morning, and kind of it was really helpful to think about how this group moves forward. I don't know if we're still gonna be looking at the areas that we want to focus on more, but it's certainly getting greater resolution there. As this group moves forward with that, I was wondering, do you have any insights on how changes in federal funding, Medicare, Medicaid would influence the kind of the workforce shortages that we're looking at in the years to come?
It's a great question. I'm not sure anybody exactly knows the answer to it. I'll take a stab and you're welcome to add if you want to. I think what's hard to know is based on the types of changes, how those are going to interact with kind of our healthcare system here in Oregon. First wave of federal changes we'll probably see, which we'll see next year, is work requirements and increasing the eligibility checks, which will roll in, which is probably going to increase the number of uninsured, because we're going to have people who roll off Medicaid. So depending on the provider type, that could affect the organizations differently. Like you'll probably see higher ED volume. So you're going to, like, hospitals may need more of certain types of workers. Starting in 2028, we have a different kind of impact in the state, which is a funding impact to our provider tax program, which is one of the ways the state funds its general fund share of Medicaid. And that impact is like $15 billion over 6 years. It's massive. So that creates a state budget problem. And how the state resolves that budget problem, do they try to resolve it within the healthcare pie? That will be hugely disruptive. Or do they try to resolve it within all of state government? Because it's fundamentally a general fund budget problem, which is a different question. So we don't really know. That's the hard part for Oregon. In other states, the funding impact is much more direct to healthcare providers. In Oregon, it's really a matter of the state budget. And so the decisions that are made will impact what that means for providers, which will then mean what it means for the healthcare system. But I think what we do know is we are going to probably go from a 97% insured rate to something less than that, which will put more pressure on our hospitals and on hospital employment. Yeah. Did you guys have anything to add to that? No, or anybody else is welcome. Like, I don't have a crystal ball.
Our take of the same thing that I like time will tell what this is gonna do to our patient population, like how many will lose their Medicaid coverage in the next year, and we don't know. Can I tell you which one of my clinics will be the most impacted? Yeah, my pediatric clinic, my OBGYN clinic are heavily Medicaid population that are there, upwards of 60%. And so how do we, number one, help those people? Because there's those people that just aren't going to reapply because it's over their head to reapply. So how do we help them if that happens? But as we sit at the table with the CCO and looking like at what their struggles are, I can't help but sit across the table from them and think, well, what role can I play in this and helping their patients get care at the right level? Do a lot of their patients show up in the ED unnecessarily? Absolutely. Is it because we have a shortage of primary care access? Absolutely. So, we can do what we can to add more primary care and try to keep those patients being seen in a more affordable place to get care. Is it better for them to be seen in an urgent care versus an ED? Yes. How do I drive their population that way? So I think that we have a role to play in how we help them get the right care. I think it's just a different way of looking at it sometimes.
Yeah, and I think to build on that, and I know we're hitting time, but
You're fine.
Indulgence, we're okay.
Questions.
I think in some of these areas, you're looking at a really complicated intersection of workforce availability and funding. And so particularly in OB, and I want to highlight that because because the state Medicaid program pays an average of 56 cents per dollar of cost for healthcare. So when you look at a service like pediatrics, like OB, which is, what's your Medicaid, I mean, it's 60%, yeah. High volume of Medicaid, you already have a money shortage because you're not covering the costs. And then you try to recruit providers, and in some of the most challenging areas, particularly OB, which I know Seaside has recently had, has recently struggled with. And what ends up happening? Well, you have to shrink services because that intersection of provider availability and money just doesn't work anymore to create that safe care environment. And so I think those are the kinds of things we're going to have to wrestle with as we work through the next couple of years.
Who needs to ask a question?
I have a question, and then just to kind of address your question, Rob. I think what we're gonna see with the implementation of HR1, and like you said, we don't have a crystal ball, so we have yet to see how things will play out. But I think with the elimination of the graduate plus loan, it's gonna become a lot more difficult for students to pursue graduate programs, MD, DMD, PA, graduate nursing. Those programs are going to become much more difficult to access, in particular for economically disadvantaged students. I think it's going to shift the demographics of our student population. And then once those students graduate, because of their high loan debt, they're going to maybe opt towards more specialty care that pays higher and more urban areas that pay higher. So I think there's going to be some really big impacts that we all need to keep a really close eye on. And then my question for all of you was, so I work with our academic programs at OHSU, and one of our biggest barriers to growth are clinical placements. It's probably, among the top 2 to 3 barriers to growing our academic programs. So I'm curious from an employer perspective and a hospital perspective, I'm just curious kind of how you view clinical placements for students that are training and rotations.
We welcome everyone.
Wonderful.
It's housing and hotels.
Yeah.
Generally, a lot of times the students, it works great if their grandma has a beach house, but other than that, I know enough money for a hotel.
Yeah.
It's been a great challenge.
And I think the other challenge comes to that. I mean, this is just super logistical, but we have to have the space in our clinics for another body. And so you start to run out of room when it comes to that. Send us every resident you've got though, because what we have found is when it comes to recruitment, if they come to us for residency and they've had a good experience, they're likely to decide, hey, wow, I kind of like this rural living. I like this coastal life. And it's a great way for them to kind of dip their toes in the water. But I think we will take as many students as we possibly can.
2 quick questions. One is, I think, and I want to clarify that I heard Providence Seaside is using a tuition reimbursement model. Is that based on course or certificate or degree completion and reimbursement?
It's reimbursement. We do partner with the Guild program if it is in there, unfortunately. So, which means that then we can pay on behalf of the student, and it's $5,250 annually.
Okay.
Reimbursement, so they aren't taxed. Or they can submit for reimbursement, and it just has to be a program of accreditation. So any college program, but they also do certification programs too. And we do have a policy system. You have to kind of submit through HR, and then all they have to do is prove that they paid for it.
Okay, so it can be reimbursement, or you can pay the college directly.
If the college is in our pretty robust list, unfortunately, CCC does not have it. I'm working on getting it in the major universities such as Western Carolina University, large university systems are in it.
Okay. And then did I hear CMH is, you're actually paying the institution directly for?
And so we have a very similar program for reimbursement for a number of programs that would be existing, like say outside of anything that Classic Community College offers. When it comes to like the MA program for Classic Community College, we are paying Classic Community College for up to 8 students every year for MA programs. Nursing, I have to check on how many scholarships, and then they were also doing scholarships for the CMA program here at college.
Okay, and then the increase in MA program enrollment, do you know what that is the result of? Are there particular efforts that the community has been making?
I can tell you every one of our apps, so we had 25 applicants for our MA intern program, and obviously we turned 23 of them away because we could only take 2. And so where we sent them to was the community college. Now, do I think that's all of them? No, because I think that, again, there's people that need to still make a living wage while they're attending the MA program. But I do think a lot of it is people who are having interest in self-care, and as they're looking at the debts that come with something that's bigger to get into, an MA program is a 9-month program through the community college, a pretty easy entry level to get into with doors that open up as you get into there. Then it's a great stepping stone to nursing school. So I think people are starting to view it a little bit more as an opportunity to get into different different areas of healthcare. I think the other thing that I can say for us specifically is we recently went through some union negotiations with SEIU. The MAs are making a really, really good wage. And so I think that's probably helped with that MA program to know that, hey, I can graduate and I can actually earn a good wage.
That's great. I'm just thinking that was such a huge gap in not enough applicants on the data that you presented, Gail.
And I think the point is really a good one, and we've seen this in we saw this in Southern Oregon too with Sky Lakes, where the ability to employ someone while you're training them for that cohort makes a huge difference.
If I could do more than 2 at a time, I mean, you need classroom space, you need those kind of resources. And so, well, we've just kind of maintained doing 2 at a time, and so we can get 4 new MAs through a year, but that's 4 more MAs than we were able to get before.
Thank you all so much. All right, well, we're transitioning. Wanted to give you all a few minutes to start to think a little bit about what our priorities for 2026 might be. And so we're just going to spend the next probably 10 minutes hearing from you what your priorities for the next year are and where you would like the consortium to focus its work. We've heard from a number of folks today about some things that might inform that. But the idea is that our discussion today will really be a primer for staff to start working on a work plan to share with y'all in the first quarter and help to guide our work for probably the 2 years to come. We're thinking of a 2-year work plan. So again, this will be the last time we're having this conversation, but we really wanted to give you all the opportunity to share with us where you would like to see the consortium focus its work in the next couple of years. And that might be a particular occupation pathway. It might be a particular piece of data or information that you'd like to dig a little bit deeper into. It might be a particular career or credential pathway. So I just want to open it up to you all. What are you thinking about for your work in 2026? What are you thinking about for the priorities for this group for 2026? And I'm just going to capture some of those on the flip chart. Thank you.
Well, one I pin it at in my earlier comments regarding the First Lady Behavioral Health Council. And I think it would be valuable for us to keep that at the forefront for us as a priority, especially with those recommendations coming out. And I wonder if there's also through that work, if there's some sort of way we could be proactive in terms of, we're waiting for the recommendations, we're having conversations around how the healthcare consortium can be useful. But I wonder if there's an opportunity for us to put forward some sort of proposed strategy in terms of how we connect the work and the recommendations of the behavioral, that council to what we can, lean into as a consortium. So I just wanted to put those out there as an opportunity and also a point of curiosity to consider as we move forward.
Great.
I think one thing that'd be helpful for 2026 is I don't know exactly how many grants or where we're at in the grant cycle, but was to do a real analysis of our grants and figure out which ones have been successful or like we feel like have had the most impact. And then start to think about like, okay, what's the next step for these? Where do they live? Is this the right investment? I just think that I think we hear from our grantees a lot and I think that's really valuable. I think it's a really key part, but like really starting to actually make recommendations based off of the lived experiences of these grantees and which ones have had the most impact, I just think it takes the work of the consortium and the work we've been doing to the next level of actually figuring that piece out.
That's great, and I'm mindful that at your Q1 meeting, you'll hear the year 3 annual report, year 4 annual report for Future Ready Oregon, which will now have another full year of wage and employment outcome data for the education and training participants. So thinking about outcomes through that lens. And I think we have posed the question to all of you. I don't know how many quarters ago, but we shared with you the entire portfolio of healthcare related grant investments and sort of thinking about, Melissa, to your point, hearing from grantees is helpful. But then is it a particular strategy that's working or a particular partnership that's working? How can we better understand what's driving outcomes? I think that's what I hear you saying. And so it's looking at it more holistically than maybe pulling out bits and pieces.
I think that's right. And I think if there's any analysis, I mean, I don't know what resources there are, but like a quantitative and a qualitative analysis of like, just like the actual grantees, their actual work. Like, I just think that's like, and because I do think that's only valuable because the grants are gone. So like, if it's only valuable if we then can say, we learned this thing, we should do more of this, right? Like, I think that's the only way that money is going to go to good use. Otherwise, it is a good idea that will go away. And so I just think that's an important piece of the puzzle. And from there, I think we should be thinking about partnerships and where and how do you leverage some, public foundation partnerships or whatever for the next step of those grants and that work.
That's great, thank you.
I think currently we have a climate and then more cuts are coming in the future. Keep an eye on this issue, so important, I think, for the consortium. So how do we continue looking at this issue that's impacting our community already, but more so in the future, in terms of the cut, in terms of federal cuts, in terms of our economy, in terms of the cost? And what can we do in that space of work? Working with our partners, working with associations, working with the governor's office, working with OJ, to address these issues.
When you say these issues, I just want to make sure I'm capturing it properly, but like workforce needs. Right?
Yeah, because all these cuts that happen at the federal level, plus our economy, it's going to impact workforce recruitment, retention, and training. Yes.
Okay, great.
I think related to that, it's keep workforce at the forefront, but I also think paying attention to our budget reality. I think we have a tendency to be very aspirational in Oregon, which is a very nice thing about us, but it's out of alignment sometimes with our budget reality. And so I would like this group to kind of wrestle with, are we being realistic and focused, or are we being aspirational? And it's fine if this group wants to be aspirational and make aspirational recommendations. But let's be clear about that.
Yes.
Or do we want to be focused and targeted and actually lift up things that are actionable?
Well, and to Melissa's point, understanding what's working and not working, and how can we most effectively use our dollars?
Yeah, because there are fewer dollars, and I hate to see this group march forward, assuming that the resources are as they've been, because they're not.
Yeah, right.
A couple observations, and I'll kind of end on kind of commenting on Cheryl's observation. One, I totally agree with what I'm hearing. Let's learn from the Future Ready Oregon grants. We don't have much money. We need to get the most bang out of our buck, and I think there's going to be some good lessons there. And absolutely agree, we need to partner with Behavioral Health Council and move forward. This group seems to be well placed to do that. But I'm still left with, I wish that the panel was great. it could have been a longer conversation that could have helped informed us. And I feel like we could almost hear from a broader set of constituents that can't speak kind of national. We have many of the right people in the room, but I'm for the past couple of meetings, I've been looking at which job should we focus on? That's kind of, I think we need to do that, but that might be kind of short-sighted. I'm just really struck, when I see Liz across, I'm thinking, wow, the CTE programs, they're doing some great stuff. And we should maybe have you on a panel talk about all the things, because I think the pipeline is really important that we need to be thinking about K-12 and CTE. Coming from the university environment, I'm recognizing the community colleges have a very different, well, not very different, but have a different role than the universities. And so I think what K-12 CTE could work on, what the community colleges work on, the imaging tech we heard about, surgical techs we've heard about before, and what the universities can do are going to be different. So I think that could be an important lens. But kind of ending on the funding, and if we're putting a bunch of things up there, I don't even know if this is appropriate, and I'm surprised what I'm about to say hasn't been discussed that I have heard. Does this group have a role in lobbying the legislature in terms of funding priorities? If I have limited funding, to say, hey, we've learned from Future Ready Oregon, we've done a deep analysis on where the needs are. This is the type of investment we need. It's not going to be $200 million Future Ready Oregon type of money again, but this is what we need to move the needle on the most critical things. And so I just asked the question, is that appropriate for this group to begin those types of efforts to bring the dollars that we need?
Great question.
Do you want me to have an answer to that?
You do. Yes.
Yeah.
I think what's important is to think about the consortium's role as advisory to the commission and the Workforce and Talent Development Board. So this group can absolutely prepare recommendations that we could then present to the commission or the Workforce and Talent Development Board. We can present to the governor's office. Rob and Marin are both participating in Racial Justice Council Workforce Work Group that's wrestling with some of this idea around policy and funding recommendations in the workforce and talent development ecosystem. So you definitely have a role to play, and I think partnering with your fellow consortium members where it makes sense. And then we've overlapped with the Workforce and Talent Development Board leadership as well through Dr. Bennings and others who are here today. So there's absolutely space to be presenting and advancing those recommendations, and the sort of who, what, when, where, how will depend on where the focus and the priority lies.
Hey, Jennifer.
Was that sufficiently vague?
Yeah, I'm getting operationalized out, but.
Yeah, I think this, the devil's in the details, but there is certainly a place for this group to be advancing those priorities. Yes, Liz.
Thanks, Jennifer. And thank you, Rob, for advocating for K-12. I would be happy to pull a panel together of some of our best career and technical education teachers that are in the K-12 system. These students are getting services and certifications free of charge along with graduating from high school. And then we can get them to become medical assistants, dental assistants, behavioral health, and then they can utilize Oregon Promise and go to that community college partner. So a lot of these things are already happening across the state. So I would be happy to convene some of these teachers with their best practices and some of the things they've been seeing in their communities. And I'm happy to do that.
I do think we heard a lot, both from Gail and from our first panel about some of these entry-level opportunities, and both questions and assumptions about the stackability or advancement opportunities within those healthcare occupations. And so thinking about what are those pathways to college and career, what are those entry-level opportunities, and then what are the where might there be barriers to career advancement, that could also be a space where there could be real policy barriers that this group could address. All right, other things. This is such a great list to start with. Yeah, Logan.
Can I say something even though I'm not?
No.
Okay.
Yeah.
I know that would be fun if I thought this and didn't ask. While the panel was sitting out there and just to what you just said, Liz, I was wondering, there are these great pipelines for local employers, but there are gaps in terms of barriers to students coming in. So like, if not for these barriers, they would have more coming in.
Mhm.
And there are also service gaps to look like education gaps in terms of local CTE programs, not necessarily meeting needs for local healthcare providers and employers. And so I'd be curious if that panel was, I would want to be a clown on the wall, but I would be curious, from the employer's perspective, if they said, here's what people aren't learning, but if we fill that, we want 3 more, or if we could cover this wraparound service for all of our students before. Because that's where the workforce work could very easily step in, like, we have funds for that. So.
Yeah.
Yeah.
That's great, and I think too, in this space around barriers to entry and advancement, I think going back to Melissa's question, because the Future Ready Oregon funding was so flexible and really focused on filling those gaps, and meeting sort of individual needs and individual barriers, we are learning a lot about what those barriers are, what the cost to addressing those barriers are. And then we have some qualitative findings to couple with that, where, folks will say things like, but for that, fixing that flat tire, I would never have reached this credential, for example. So I do think as we're diving into more about employment and wage outcomes for participants, and better understanding those barriers and strategies and costs associated with addressing those, we can get to some of those pieces in addition to the credentialing, what's missing question. So thank you for that. All right. Well, we are now going to transition to our panel of folks from Nehalem Bay Health Center and Pharmacy. And as they're coming up, I will let you know, I mentioned briefly, and we've got some slides with some great pictures for them, but a few of us had the opportunity to visit their facility, which is in Wheeler, which is about a half an hour north of Tillamook, accessible by Highway 101. And they're going to tell us a little bit, we've got name cards for y'all. They're going to tell us a little bit about the grant funded project and how they have employed that in this region, and I think that did I have the wrong name?
No, you
Oh, okay. And I think we're gonna hear a little bit about their new facility in the next couple of weeks. They're gonna be moving to a brand new facility, which for those of you who drove down from Astoria, you got to see that from 101. So I'm gonna turn it over to you all, and we'll have some question and answer if we have time. Otherwise, they're also going to be joining our panel with Tillamook Bay Community College a little bit later. So take it away. Wonderful.
So could we have the first slide, please? Excellent. My name is Maria Carrillo, and I am the Pathways to Equity Coordinator for what we know is a Future Ready grant in our county. Pathways to Equity is what we decided to call program locally. And when we started this journey just 5 months ago, we started in April, we did not realize the impact that this grant could have on our community. And we're slowly getting to realize what it means to us and to the community and to our partners as well. For now, I'm going to invite Gail Nilsson for a few minutes to talk about what it does mean to us so far, what we know, and when she is done, then I will continue with our presentation.
Thank you, Maria. And I'd like to take a moment and thank the Oregon Higher Education Coordinating Commission for the opportunity to collaborate and work together. At the Nahila Bay Health Center and Pharmacy, we understand that strengthening our coastal healthcare workforce means lifting all the boats in the harbor. When we designed the Pathways to Equity program, we knew from the start that as a health center, and as the second smallest health center in Oregon, it wouldn't be feasible for us to employ all of these graduates, healthcare graduates. That wasn't the point. The point was strengthening our coastal workforce for all of us. We've taken on the role of workforce development catalyst, not just the employer. Our collaborative approach to building regional healthcare capacity means that when these future healthcare workers are trained, the benefits ripple across our entire coastal healthcare system. We hope and expect that our graduates will be working across multiple healthcare organizations throughout the coast. This will likely mean reduced recruitment costs for our partner clinics and hospitals. We also think we will significantly improve healthcare access across our coastal communities because we're helping to build a local talent pipeline instead of all of us competing for external hires. We've developed working partnerships with other providers, and when one of our future scholarship recipient graduates and goes to work at another facility, it's not a loss for us. That's exactly the success that we are aiming for. The partnership approach to workforce development isn't just good for our communities, it's better than that. It's a sustainable model that can be replicated across rural Oregon. Once again, I would like to thank the Coordinating Commission for the opportunity to collaborate in this work together, and to all of our community partners for their support. And now I'm going to turn the program back over to Maria to share some really exciting news about this program. So thank you, Maria.
Thank you, Gail. So again, when we started this journey, we just didn't really know what to expect, but we did have high hopes. My boss said, well, you're really not gonna have any action until the fall. But that wasn't the case. We have awarded 20 scholarships today, starting in April of this year. 6 of those students come from Yakani High School up north in our county. One of them came from Nisaka High School down south in our county. All of these 7 students were 2025 graduates, so they immediately chose a career path on graduation with the help of the scholarship. And about 8 of these 20 were referrals from our partners here at Tillamook Bay Community College. And what I love about this group is how diverse they are. We have from brand new high school graduates who are ready to jump into their career in healthcare. We have a couple of moms who are have small children. And to me, these moms, their determination has been very, very inspiring. We have adults who are ready to complete a career change, bringing their life experience into the new healthcare field that they are choosing. And our students are pursuing different healthcare pathways. We have a little variety going on. We have nursing, phlebotomy, dental hygiene, medical assistants, doula, CNAs, and EMT. And they're primarily spread across 4 colleges, some staying here locally at Tillamook Bay Community College. One went to Portland State University, other one PCC, another one Lane Community College, and 2 others to Chemeketa Community College. And let me give you an example of our progress with some testimonials and some student stories to help you relate to what the impact is locally to us here in the community. So one of our education partners, this is the principal at Neocotty High School. Her name is Christy Hartford. She said, these scholarships provide access to opportunities that may not have otherwise been possible, removing barriers for students in rural areas. So this is from a high school principal's perspective. Then we have the school counselor from the same high school. Her name is Esther Troyer. She said, this is changing lives. And she's so right. And from one of the graduates from that same high school, her name is Peyton. She told us, thank you so much for this scholarship. This will be such a big help with my future education and career in pursuing dental hygiene. I'm excited to return and give back to my local community. So it just touches your heart. They're thankful and they want to show it by returning to our community. And now we have some stories about students here at TVCC. And now we have some pictures. Thank you. So our first story is Vanessa. Vanessa completed CNA training over the summer here at TVCC, and she's now at Portland State. And she's pursuing additional prerequisites with sights set on becoming a nurse and then eventually a nurse practitioner. So she's got long-term goals, but she's starting here. So coming from a Spanish-speaking family, she brings crucial bilingual skills to healthcare. Her journey from community college to a university in 1 year shows pipeline acceleration. Her cultural competency development and our investment in advanced healthcare providers with this fund. And now we're going to move on to a different student. His name is Morgan. And Morgan is the one sitting on the grass. Morgan is a volunteer EMT. He completed his prerequisites over the summer and has now been accepted into TVCC's nursing program. He lives with his brother for financial support, and he leads student government at TVCC. Morgan demonstrates how prior healthcare experience enhances readiness and leadership skills transfer to advocacy and create solutions to financial barriers. Now we're going to move on to a different student. Her name is Anna E. She is on the same slide. Thank you. She's the one in the pink t-shirt. So Anna E. completed both CNA and phlebotomy over the summer at TVCC, all while raising her 2-year-old daughter, working at Starbucks, participating in student council, and gearing up for TVCC's RN program as her goal. And this is while her husband has been unemployed and looking for work. And because of that, he has been the sole childcare provider to allow her to have this education experience to keep going forward on her goals. She comes from a Spanish-speaking family. She shows grit in the face of adversity because she could have said, hey, this is too much. I need a break. I'm going to step back, but she hasn't. And now we're going to move on to our last student on the slide. Her name is Leah. Thank you. And Leah is a single mom. She works 3 to 4 days weekly while taking prerequisites, and she is starting EMT training this month. She's working towards nursing. She also demonstrates work-study integration. She models educational persistence for her daughter. Her daughter's about 7 years old. And she shows a systemic progression toward her goal, even if it is 1 or 2 classes at a time. And it is noteworthy to mention that Leah lives in Garibaldi, which is about 10-15 minutes up north. She takes her daughter to daycare in Nehalem, which is about 35 to 40 minutes up north, every morning so she can come back down to Tillamook to either work or to go to school. And then she repeats this process in the evening to go get her and go back home. So you take a look at our students and their causes, their challenges, their barriers, and we are able to come up and support them financially. It's all worth it. We are, like the school counselor said, we are changing lives, and we believe that. So now we know that there are challenges, but one thing that we love is that we have acquired some partners in the process that have helped us with these students. And TBCC has become one of those true partners. So they are actively referring worthy candidates to the program, and we love that they do that because it's hard to get the word out in a rural community. So now what we'll do is we'll turn the floor over to Katie Summers, who is the healthcare coordinator here at TBCC, and she will speak to us as our partner in this endeavor.
Thanks, Maria. I'm Katie. Just to give you a quick background, where I come from. Years ago, I ended up in a situation where I was a single mom and needed to go back to school. And when I faced this daunting path, I thought, how am I going to do this, right? How do I juggle this? How do I afford this financially? I know I have some family support, but I was able to get a scholarship and able to go to community college and get an associate's in physical therapy so that I had a way to provide for my family. And after that, I was able to go on and receive further degrees in education. But when it came time for me to go to work for TBCC, I felt very strongly that we need to be able to support our students. And when I found out about this grant, I was so excited. All of the students who come to me, they get to come into my little cubby space, and I have a little bench, and it's really low. And I always warn people, you know, if it's a little bit further down than you think when you sit, they get this look of panic when they finally hit the seat. Like, I'm sitting on my bench, and let's talk. Let's see where you are in life. Let's see what you need. What can we do for you? And I have given out their information so many times. I have it saved to my desktop, so I automatically just download an email and I send it to them automatically so that they can fill it out. I'm not sure on the total number of students who've actually followed through and applied, but a number of the students that are on the list that Maria sent to me, they were on there. We have students in every single one of our programs that are receiving this scholarship funding. And I know they wouldn't be able to make it through the programs without that assistance. As Gail mentioned, we have this idea in our community of grow your own. Because we are a small county, we try and look to the resources that we have in our students to grow our own healthcare providers. And what a blessing this opportunity has been for us with TBCC. We've had an interest in the number of high school students. We went and talked to all of the high schools this last year and spent time there discussing what the students were looking forward to and how we can help them, assist them in their education goals. And this scholarship money has been a huge benefit to them as well. And so at TBCC, we're just excited to partner with the Halem Bay 2 and so excited for their new clinic opening. And they presented us with opportunities for like our MA students that we weren't anticipating, and we're very, very grateful to them. And thank you for letting me come and speak with you.
Thank you, Katie. And yes, we do have a ribbon cutting for our new building October 4th from 1:30 to 4. And anybody in the community is welcome to come by and see our new building. We're so excited to move into our new facility. Just means growth all around for everybody. So I'm going to talk just a little bit about the results and the impact of this grant for us. Our timing turned out to be, I'm going to call it perfect, because we launched in April, and that meant that we caught the sweet spot where the high school seniors were having to make decisions about their rest of their life careers, hopefully. And so we were able to help 7 of these students jump right into summer programs here at TBCC. So education started almost immediately as soon as they graduated. And these 20 students represent future healthcare workers who will be distributed across our coastal community. And this isn't just workforce development, it's actually a community resilience building exercise, a good sustainable model. Partnerships that we have developed are exciting with our local high schools and our community college here at TBCC. We look forward to growing our program. These last 5 months have taught us that it is possible. We can do it with the assistance of our partners. This can happen, and it will happen. The energy and the gratitude from these students keep us motivated every day. We get emails from students appreciating how much what this means to them. Get them over a hurdle, get a challenge met so that they can keep going every day with their goal. So this workforce development really is working, and we're excited to continue collaborating with the Higher Education Commission and our partners to strengthen Oregon's future in healthcare. So if there is time, we're happy to allow a few minutes for questions and answers. And if not, we're happy to take them at the panel at you.
I think we have a couple of minutes for questions if folks have questions about the
You know what,
grant.
I just want to applaud your work, by the way. You know, when we started Future Ready Oregon discussions back in 2022, I mean, now you're seeing the reality of what the work is doing. I mean, it's just awesome. I'm so heartened. It's heartfelt, the work that you're doing, honestly. So I applaud you for all the great work that you're doing.
It was a group effort.
Yeah, you can tell your passion and your energy for the work that you have and the love of your students. That's tremendous. Thank you.
We want to see them succeed, and all of these details that I shared with you, they're shared with me from these students. So I try to provide support that they need by getting to know them better so that we can meet them where the challenges are and help them over the hurdle so they can keep going. Because this is going to benefit us all here in our community, not just us as the employer, but everybody. Everybody's boat will float.
Well, I'll just comment, many of you know that I lived in Tillamook for a number of years. And my kids all graduated from Neoconi. I had the opportunity to stop by there yesterday, and I'm just reminded that these students, you can imagine Neoconi School District serves students. It takes nearly 40 minutes to get from one end of the school district to the other. And when you think about having to come to Tillamook Bay Community College to access whether it's dual enrollment or these types of career-related programming, that's a huge barrier. There's not a school bus that provides that. So there are kiddos from 45 minutes to an hour north that have to take time out of high school to get down here to the college to take classes. The example of the young woman who has childcare in the Halem and lives in Garibaldi and comes to Tillamook. This is just part of daily life here, but these are real barriers to accessing degrees and credentials. And I had the opportunity to meet with the school career and college counselor at Neoconi, and she shared the same quote. If this investment in these students' lives is really changing the trajectory, providing opportunity for them to access workforce opportunities and further education opportunities that they might not otherwise have known were available to them. So I appreciate you all sharing their stories with us, and we look forward to learning more and hearing more from the TBCC program and panel here in just a few minutes. So if there are no other questions, thank you all so much for your time. We are going to take probably 10 or 15-minute break. We have lunches at the back of the room, so please help yourself. And in about 10 or 15 minutes, y'all can leave your name tags up there because you're coming right back up. We'll have a great panel, and then we'll be able to take a tour of the building next door. So ready, break.
So we're gonna dive in for Gosh, the third of a beautiful segment of panels that have happened today. And so, I'm so thankful to, my peer, my colleague, President Terrell here at, Tillamook Bay Community College, because, we share a lot of the challenges and the pressures and the experiences as community college presidents. And one of the highlights here at Tillamook Bay that we're going to dive into is, the power of collaboration and partnership, but more so around the launch of the new nursing degree. And then I know some of the team is going to take a tour of the new facilities or the new spaces. And so I want to start with, I know we heard from a couple and you did introductions, but we're just going to dive right in again for introductions so everyone can just familiarize themselves with who you are, your title, and your role. And we'll start with introductions this afternoon. So I'll just go right to my right, your left.
Again, nice to see you all again. Paul Gerald, president here at Tillamook Bay Community College. I've been here for starting my 4th year and president for coming up on 2 years.
I'm Katie. I'm the program coordinator for nursing and allied health. I've been with CBCP for a year.
I'm Dr. Tiffany Slover. I'm the Dean of Nursing and Allied Health, and I think I've been here since December 22. Yeah, that sounds right.
Hi, I'm Eric Swanson, the president of Adventist Health Tillamook. I've been with Adventist Health Tillamook for about 35 years in the president role for 6. I am a former TBCC student and instructor.
Gail Nelson, CEO of the Nehalem Bay Health Center and Pharmacy. I have been with the organization since 2019, and I'm originally from Illinois.
I am Maria Carrillo, Pathways to Equity Coordinator at Nehalem Bay Health Center and Pharmacy. I have been with Nehalem Bay for 5 months, coming up on 6 months now. Previously, I was with Tillamook Bay Community College for about 3 years.
Awesome. Well, thank you for being part of this panel and sharing your insights and experiences, because I always like to lead into learning opportunities from these types of spaces. And so there's no rhyme or reason or methodology to how these questions go. You feel free to chime in. And then if I don't hear from you, I might call on you, but this is not classroom stuff. I'll try not to do that. But we've heard about the rural coastal community and some of the challenges around serving and providing opportunities for the workforce education and training. And one thing that I'm curious about is, given the unique opportunities as a rural coastal community, what does it look like in terms of not just the opportunities, but the challenges in providing those education and training opportunities in a rural coastal area? So I'll put that out there for the table.
One challenge for me is how to get the word out there. In our community, there isn't like one method of communication that is prevalent among our communities. There's several ways. And we're a little bit on the old fashioned paper, Facebook. But yeah, challenge of getting the word out. This support is available within our community.
I can. So some challenges to getting started. So first of all, we were lucky that we didn't have the challenge that we needed to go really drum up community support. We had community support from the beginning, as you saw. As Eric mentioned, I'm still waiting for him to provide those kickbacks to TBCC. He owes us everything for where he is right now. We had those community partners. To the point that the hospital, Adventist, and Eric has supported the college in our programming from the very beginning, whether that was EMT or partnership programs that we had with Oregon Coast for registered nursing. So we've had that community support. We had, the community support for the facility that we're building. We passed by a bond, a $14 million bond, along with some matching funds from the state to be able to build that. So we had that piece. But when I started here, the president at the time said, "You've got one job, and that is to start a nursing program." Right? And we had.
So you're done.
Oh, I'm done, yeah. And that was to start the nursing program. There are 17 community colleges in the state of Oregon. We're the 16th largest, by the way. We were the only one without an associate degree in nursing program.
Wow.
And so I came here and I started, and I think in the first 3 months, maybe 4 months I was here, as you know, working with the State Board of Nursing, we needed to have a nursing director who was qualified in that. And I think there had been 3 in my first 3 months here, nursing directors. So that has been the biggest challenge, or was the initial challenge, was providing that kind of required staffing that we needed to be able to start a program, apply for a program, and offer the program. Luckily, I met Tiffany, one of our prior nursing directors, gave her resignation the day before our first visit to the State Board of Nursing. And I'm like, what do I do? I'm a biologist, so I was at least familiar with some of the requirements. Luckily, I was introduced to Tiffany, and Tiffany's been on board with us since that start to really kick the program up and get us started. But that staffing piece continues to be a challenge always, to try to recruit and retain teachers as well.
So I think one of the challenges that we're going to face, being a small critical access hospital, I had this discussion earlier this week about how do we give good clinical experiences to 2 cohorts of nursing students, CNAs, new grads that we're hiring as residents. How do we make sure that we give them the best experience possible with a limited number of patients? So we've done some creative things to do that. Some of our nursing students have spent time in the clinics with RN care coordinators that will go out into the field or see patients in a ambulatory care setting, not in the hospital. So that's one of the challenges. And one of the challenges I'm really excited about is there's going to soon be more nurses graduating than we can hire, which is completely different than we've ever had in the last, let's say, decade or more. That the program here at TDCC is a game changer for us at Adventist Health.
I would agree. And thank you, Eric, for setting that up, because we'll help you hire. We find that it's difficult to recruit nurses for some of the reasons you've already heard earlier today. And it's going to be very special. And I was so supportive of the college with their ideas for the program, because we knew it would benefit us. And it's really needed in the community, and I'm sure our other partners in the room will agree. I can see heads nodding in the back, and it's something that we'll all benefit from.
And both Gail and Eric were on our bond campaign. So I mean, that's the partnership to really kind of bring the community together to really help, this vision, right?
Yeah. One thing I heard around the community support that was, that's so fundamental and foundational to initiatives such as this. And it speaks to, in my mind, my own words, the trust and the reputational aspect that has been established in the community with that support, which is reflected through the successful bond passage. I heard about the challenges, good and, bad. It was a good challenge. I think every challenge can be a good challenge, right? Depending on perspective. One of the questions I want to ask is, can you in general share the journey of the vision and how those challenges, or what led to the thought or the idea of saying, you know what, we need to, or we should do this. So walk us through the journey and your role in that journey and how it came to be where we are today.
So I was in another role. I'm going to tell Sarah's story.
Okay.
I was in another role, and Sarah worked for me. Her mother worked for me, and her dad was a deputy sheriff with me when I was in law enforcement. So I know this family very, very well. And Sarah was a rock star phlebotomist. She was amazing. And we were affiliated with TVCC didn't have a program, so we were using another college on the coast, which will remain nameless. And Sarah tried it over and over and over to get into a different nursing program. Sarah's a 4.0 student, amazing clinical skills, amazing rapport with patients, and she didn't get in after 2 years of trying. So she made a decision to go to Chemeketa, and they accepted her. So where does Sarah work today? Salem. They're lucky to have her.
Wow.
Where does Sarah commute from? Tillamook County.
Really?
And that is she would have been second generation employee in our hospital, right? Which means something. She's taking care of her family and friends in a rural community. She's an amazing nurse today, and we missed that opportunity. And it was at that point, I'm saying, we've got to make a change. We've got to, when we talk about homegrown students, we need to make sure that we take care of our, give them the opportunity to learn and grow in the environment that they're in. So I would have Sarah as a nurse today with almost 10 years of experience. But my friends at Salem benefit from her amazing care. So that was one of the things that to me said, we've got to do something different. And to be transparent, we hire more people from Tillamook Bay Community College than any other single source. Whether it's EMTs, phlebotomists, nurses aides, MAs, and now RNs. And I'm working on him I call Paul and say, he doesn't take my calls anymore. Paul, I need surgery techs. Can you do that? What about limited license rad techs? Have you ever heard of that? So recruiting in a small community is difficult. I was just reviewing some data from A&M, which is a national physician recruiting firm that we use. And their data shows that 3% of physicians who are coming out of residency today are willing to live and work in a community of less than 25,000. Less than 1% will come to the community of less than 10,000. And that's us. And that speaks to the difficulty in recruiting. So if you can start a medical school for physicians.
I'm on.
Yeah, good.
But Eric brings up an interesting point about access though, right? Because you typically think of access, you have a 4.0 student, ties to the community or whatever, wants to live here and be here, you would think that person's going to be in, right? But there are still those barriers that are built into it. And, nursing schools to some extent have become a numbers game, right? You get X number of applicants, you figure out one way to immediately cut them in half, and then you start whittling down from there. When we started our program, we did it with the intent of wanting to be very different. We didn't want to be that typical program where we might introduce those barriers unintentionally, right? So I think our first cohort, we ended up taking 100% of all applicants, I think. Yeah, I mean, part of that was because we had a small pool, obviously, to begin with, but you can imagine even within that, we had some students that were really, really qualified, right? And then we had some students that probably weren't as qualified, that probably wouldn't have had a chance, or maybe had not had chances at other places they applied. And what's our NCLEX passing rate for our first cohort?
Our NCLEX first time pass rate is 86%, the board requires 80%. So it's really exciting with our first cohort that we overshot what the requirement was. And we anticipate our overall pass rate will be 100% once some people retake their tests. So it's been really exciting because you just don't know when you put a program together, especially as Dr. Gerald said, when we accepted, we had 16 seats, but 17 applied, and we thought, we'll take 17, why not? Because to see how it goes. And we very purposefully removed barriers even in our application process, as we mentioned. So I think the biggest example, the thing that was really exciting watching cohort 1 graduate, a lot of programs have math and sciences expire after X number of years, and we decided to remove that from our requirements. So people who had been almost ready to get into nursing school prior to COVID, then COVID happened, life happened, and then their prerequisites were just expiring like in this cycle, where it's like they take this one and then that one would expire. And so they just were in this never ending loop of trying to get caught back up on prerequisites while still doing life. So I think 3 or 4 of our students were almost in tears when they found out that their prerequisites didn't expire when they applied with us. And so that gave them the opportunity to go through a nursing program. And all of those students have passed their boards and they're either working or close to getting jobs as RNs. So that was really exciting.
I want to follow up to my initial question in terms of tell us the story of how the vision came to be and how we got to where we are today. But I want to go back to a comment that you said earlier, and you talked about when you came in, your one job was to. But what did that mean for you in terms of grasping hold of the vision and then being that champion and connector to fulfilling that vision? How did you launch into that, being a new president in that role, knowing that that was a task or a charge before you?
So I looked at this from the standpoint of I'm purposefully made I spent most of my career in Southern California. But I grew up in Eastern Kentucky and Southern Ohio, very rural, when steel went away when I was a kid in the late 70s and early 80s. I saw what that did to communities, right? You lose major industries, then you start losing schools, then you start losing community hospitals, and then you lose vibrancy in the community, right? And so I purposefully wanted to come to a small community that had those components of vibrancy, right? You need access to education, you need access to healthcare, you need access to a job with a reasonable wage. And so those were my motivators, and having spent sort of my career in a community college setting, knowing how important being able to create that opportunity was, right, to not only to the students that might enroll and have that opportunity, didn't have otherwise, to break a cycle of poverty or abuse or addiction or something like that, but more to sustain the community, right? And that has been the motivator for me here, and being able to do that and drawing on the connections that we have with the community to do that. That was my motivator for moving this forward. I think the other piece was recognizing that when we looked at when the first presenter was giving the presentation on wages in the Oregon that these different occupations have, and then looking at what it means to have a sustainable wage or a living wage in Tillamook County, right? In Tillamook County, to have a sustaining wage, you're looking at if you're a single person in a household, you're looking at, $25,000 a year is considered a living wage, right? But if you're trying to raise a family of four, you're now over, $100,000 a year as a household to be able to do that, right? And there aren't that many occupations in the county that can provide that kind of opportunity, right? So I think thinking in healthcare and trying to bridge those healthcare opportunities and put the pathways together that would allow someone to move from, something like a CNA or an MA that might not have that living wage opportunity to be able to progress within their own community to be able to do that, because most people don't have the luxury to be able to leave and go somewhere else. And as Eric mentioned, when they're forced to do that because we don't have the systems in place, the community loses them. Right.
Yeah. When I look at around the table, you've got Tillamook Bay, you've got Adventist, you've got Nehalem, and one of the things that we talk about in this space is partnerships and the power of collaboration. So can you all, in your own experience of this work, speak to the key role that the partnership has played in this, and in partnering with other institutions and organizations? What are some nuances and challenges that you had to consider and had to work through as individual entities now coming together for a common mission, common purpose?
I can say from the school side, when we're working with a variety of different clinical partners, they all have their own clinical onboarding criteria. So one entity may make you do your fit test within 2 weeks. Another one, they don't care when you did it. There's different things for your TB tests and how old those can be. So we have an interesting time, and it just takes a lot of making sure we're staying on schedules. We'll have a couple students go to one setting and a couple go to another out of the same cohort. So they might have different clinical onboarding criteria, and that's a lot to juggle. Primarily Katie gets to juggle all of those fun details. So that's one thing we see, having multiple clinical partners that we're working with, trying to figure out what all of those requirements are for our students and figure out who needs to do what when, which is a lot when we've got nursing assistant, MA, phlebotomy, and EMT all running around the county.
And for me, it's been creating process, because there have been so many changes that have happened. within these, my role, I guess. That create, and I think we're a lot closer now to creating a process that's going to be the easiest for me to juggle and a lot more clear for the students and clear for those who are providing our clinical.
I would have to say that in terms of successes and challenges and nuances of this work is the recognition that we all have that we're very isolated, and to solve the problems that we face, we have to be together. And that sometimes means you leave your ego where it needs to be and recognize that we can do our best to solve and bring things to the table that need to be analyzed, and more is usually better when it comes to thought processes and brainstorming. And as a county, that's one of the strengths that I heard when I first moved here. And by gosh, it's true. And as time goes on, that's what I experience here in this county.
So I'm gonna ask this question, feel free to answer or not answer it. But, looking at how you partnered in this work, is there anything that you would, looking back, would have done differently? Did you have this, I wish I would have known moment? And then I'll give you a good one. Or was there this aha moment for you in the mix of this work?
We still have to work together.
I know, absolutely. Part of being able to address elephants in the room and transparently work together to move forward in a way that is really powerful and positive and transformative. What you're free and willing to share, what y'all have to hash out behind the scenes, I'll leave that for y'all. But anything that would be helpful to, us to just be aware of, and or helpful in terms of how we work and partner to expand this work in our own networks.
One thing that was difficult that has since been dramatically improved, both here at the college and I'm sure at Adventist and your facility as well, because we're small, we all wear multiple hats, which means 1 week, this might be your go-to person for what nurses are available to take a student with them. And the next week, someone else might be looking at scheduling. So that makes it hard for us to all collaborate when we're all kind of shifting all of our multiple hats. And so previously with Adventist, and it was all brand new too, so that added to the complexity of trying to figure out what we needed and then how to do it. That was difficult for figuring out who all needs to be involved when we have a new cohort and we're trying to figure out where can we put them, what days can we have instructors, what days do you guys have like a good enough census that we're gonna have enough for our students to see. And recently they have hired a new person into their education department who is also one of our adjunct clinical faculty, Allison, and she's kind of been able to look at things from both sides and have knowledge from both sides. And so she's kind of turned into one of our very key point people. And then things kind of filter just like with Katie here at the school. So now it's kind of like Katie, Allison, and then I have a full-time nursing faculty that also helps with our clinical rotations on our side. But between those three, it's a lot more simple and a lot less people, all the emails going back and forth and like someone gets left out. So that's been really helpful for us to try to narrow down at least an initial contact person who has the knowledge of where to direct things if we need someone else to be involved. That's really simplified the process for us.
I think that's a very real challenge when you're working across any type of, trying to build something together, is having that continuity in terms of who to connect with, because that could really disrupt some progress in small ways, which ultimately can hinder the big picture of things. Were you gonna say something?
I was just saying, having the right people in the right seats is really important, and I'm glad to hear this positive feedback.
Yeah, it's been a game changer for us the last couple of months.
Real important.
So we're any other thoughts on that question before I shift gears? Okay, so I want to shift the conversation to more so of a looking ahead type of approach. And, this is the Healthcare Industry Consortium, and we saw, some of you saw the information earlier around, the economic, the picture, the demands, and the gap between education and workforce and all the in between. One of the questions I have for you that would be valuable or helpful for this group is, what challenges or opportunities should this group be aware of as they develop recommendations for connecting people with healthcare occupations and careers and improving access to in-demand healthcare occupations? I mean, what could you offer up?
I'll comment just on some of the kind of pathway things, right? I think, when we look at healthcare and we look at the various requirements that there might be for prerequisite work or credentialing or something like that, it's really important, I think, to understand that it is a privileged person that probably gets to say, I want access to that $100,000 a year RN job, and has the ability to go get that right now, right? And especially with the communities we work for, right, with higher than average poverty in the county than we have in the state, higher food insecurities, higher housing insecurities among our students and our residents of the county. That privilege isn't always there, but we have on-ramps, right, to that more lucrative job. But if the on-ramp is a CNA, and that is not going to live in the long run, be a sustainable occupation for that person, how do we allow that person to be able to move in and out of the education and workforce to allow them to achieve that greater earning potential? Instead of saying, do not pass go, whatever, you go back, start over, right? So I think, I remember when my wife, she went to nursing school at Lane Community College, and her first year, at the end of the first year, you could sit for licensing for an LPN. And so some of the class stopped out because they had to at that point after 1 year. But then when they were able to move back in, they could move back in and complete the second year in a bridge program or something like that. But they had already made all the prerequisites, right? Because it was part of, so I don't know what the answer is, but we can't have this be a 2-step forward, 1-step back pathway, right? It has to be a pathway that's a little bit more seamless, that provides that opportunity to that greater socioeconomic mobility. And I said, I don't know exactly what the answer is, because we don't want to put all of the barriers on the front end of the pathway, right? Because that limits access. So I think we have to be creative in that piece, and I would like to see us, work towards that. Maybe there's room for, non-traditional apprenticeships or something like that might allow that to.
One piece I think that we did a really good job addressing, that was when we started our new NA program. We decided to run it in the summer, so people going into the nursing program can start the nursing program with CNA training. And it also gave high school students the opportunity to go to the program in between their academic years. And so we actually had one high school student complete our NA program. She's already passed her written and hands-on test with the state. So that gives her the opportunity to possibly work part-time, keep her foot in the door in the healthcare industry, which can be a big benefit when we later go back to have been seeing what nurses do, helping nurses, that kind of thing, if that's the path she's interested in, which it happens to be. So when we're timing what we offer, as much as possible, we try to be very mindful of, if somebody's going to continue on a path, do they have to sit out a year until they can start that next thing? So, with our EMT program, we don't run the advanced EMT at the same time. We run it after the regular EMT program. So those who want to continue on have the opportunity to continue on, if that's in their path. I think that's a little piece of, how we try to make things more of a pathway.
As we talk about looking ahead, I heard you, Tiffany, mention about the 16 seats and then expanding the one, because why not, what strategies have y'all given thought to as you continue to move the work in the program forward, in terms of, the marketing, the awareness, the accessibility, but also in terms of capacity building in the future?
I think we're in a really good spot. If we wanted to grow our program, we probably have the interest. We actually, for our third cohort that just started yesterday, we had 2 people come from California because it's so competitive. Yeah, all the way from California to Tillamook, which is kind of fun. But And we actually accepted 17 into our most recent cohort as well, because we were kind of on the fence between a couple candidates. So our interview process is not a strict numbers process like a lot of schools are, so they don't even necessarily meet students. I was accepted into Lynn Benton nursing program strictly based on my points. So we interview all of our students, we have points. We do insight testing, which is a critical thinking test. So all of these pieces play into like our whole picture of individuals when we make our selections. And so we have interest. We somehow word got around in California. So I think a lot of it's word of mouth. I think a lot of people were knowing that this program was coming and have now started their prerequisites, like our A&P class had extra lab section because there were so many A&P students in this term. And part of that is they are taking it as a prerequisite. And our one hesitation, I think, on growing our nursing class too big is the strain it will have on our clinical partners, because we are extremely fortunate that we have our own hospital here in Tillamook. We have priority for clinical placements over anybody else trying to come into the area, and that's a huge, huge advantage. Because I live actually over the hill in the valley, and schools fight over clinical placement. There just isn't enough. So trying to balance making sure we're not damaging the people that are already working in those professions, because they still have jobs to do. We don't want them to get burned out, because as nurses, we're fabulous at burning ourselves out. And that's why we have a really robust simulation space in our new building, with the intention of it gives us a lot of flexibility on, we can really ramp up our sim so we're not out in the community too much. So that would be one strategy if we decided to grow past our 16-ish cap. That would be one way that we could do that without putting more strain on it.
You have thoughts on the question? I think that to address the workforce challenges in the future, it will continue to be important to have opportunities such as the Pathways to Equity grants that Maria is leading for us, and also in the schools themselves to help increase. In the middle school, I've learned that it's important to start before high school and focus on those in the middle schools as to the potential for opportunity and a healthcare career or social skills and the important work there, and provide opportunities for students to do shadowing opportunities at the health center, our health center, or another health center or clinic in this area, so that they can try and get a better understanding of what they think they might like to do. Because then it's easy, in my opinion, to transition to the community college and all the programs that are offered and will continue to offer and expand for everyone in Tillamook County. And I think that that's important. And one of the ways that we bring to our current work life, previous experiences. And for me, that is when I came to Oregon and from Texas, where I had helped a health center start a school-based health center. And that's something that attracted me right away for Tillamook County and the Need County School District. And that is a great way for individuals to experience the medical field as an individual and young adult who is coming to the health center and sees what it's like to be an independent thinker and be in charge of their health. And that's in the high school next to the middle school in Need County. So that has also been beneficial for the community and exposing people to healthcare careers.
I would really appreciate what Tiffany said about the application process, because I hope we don't get to a place where we're just picking a lottery number. Because healthcare is about heart, right?
Yeah.
We don't want nurses who don't have a heart for the patient. And in a rural setting, we're taking care of our family and friends every single day. And as I look through this morning's census, I see names that I know. I'm walking down the hall just before this meeting, and I see somebody who's I know, and her husband's getting chemo today, so I got to spend some time with them. But it's about heart, and it's not just about numbers and PPA.
Yeah.
And so if we're looking at strategies moving forward, I hope we keep the strength of what you've created in your application process, so we get the right people to give care to me.
Wow.
Love it.
That's beautiful. It's also, I think, gosh, the mic drop moment to segue to the last question before we open it up for questions, but I want to ask each panel member, what lessons, or if this was your golden nugget of advice, what would you share in your experience or from your perspective with the group today? What would you leave us with in terms of either lesson learned or, your best advice?
I mean, from my point of view, I think if the status quo doesn't work, well, then don't do it, right? I mean, be willing to think outside the box a little bit to meet the workforce needs, and in so doing, you'll elevate your communities that you serve. I mean, we don't have the luxury, nor is it responsible to ignore any potential talent that's in our community, right? And I think we have to be willing to recognize that and advocate and look to provide the supports that might be needed for that particular group of individuals to be successful.
To go along with what he said about the importance of listening to what the community needs are. And the path that we end up taking, it's gonna diverge to try and get to that end. And it doesn't mean that there's one way that we need to go, because there are multiple ways that we can create to get the same end that we all want. And that's kind of the important things. Thank you.
I think it's really important, especially like in my role as the Dean of Nursing and Allied Health. I'm in a position to make decisions that affect everybody but underneath that works at TDCC, all of our students. I think it's really important when I'm making those decisions to be collaborative and not just make decisions all on my own, because it doesn't affect just me, but also to be very protective of the things that are working very well, even though they might not be the easiest process.
No more Sarahs.
No more Sarahs. Love it.
Like that.
For me, I think that reflection and remaining compassionate about the work that we do, whether it's Maria and I, or Eric and I, anyone else in the community, that's what I'd like to bring forward. And also, this is my first meeting that I've attended for this collaborative and the consortium. And I would like to say that I'm grateful for the opportunity to be here, because I would like to attend additional meetings.
I appreciate the strength that comes from our collaboration here as partners, because it could be a different story that we're all trying to duplicate the same service, quote unquote, and just spin our wheels unnecessarily, while we have each other to lean on and each other to rely on, that we could all do this together. Because, well, first of all, it helps us because we're not spending money unnecessarily internally, but we're also strengthening what's going on in our community environment, so that this county is a better place for all of us.
Wow, and so thank you for those words. Now, we have about four, maybe 5 minutes, and so I want to open it up for any questions for our panelists while we have their attention and they have to remain in their seats till they're done.
I have questions, but I don't want to jump in if others have. Go ahead.
I'm just so struck, Tiffany and others talking about your admission process and how different it is. And it also made me wonder about other community colleges and their admission processes. And it makes me wonder if different programs can kind of make their own admission process, and how intentional you were with removing barriers. And so I'm wondering if you could talk a little bit about, and maybe this is something for Dr. Bennings, is how do the community colleges approach admissions to programs like this? And is there opportunity for this group to make recommendations around how that looks? It seems like there's some secret sauce about how y'all are doing it. And I would bet if we looked under the hood, others aren't doing it as well.
I would say one of our really big advantages is we don't have 100 people applying to our programs like they do on I-5 corridor. So we are able to spend the time to get to meet all the candidates and build a whole picture of them. From like the regulatory stance, they don't have anything to say about how we do our admissions.
Okay.
So I would imagine from school to school, it also, like, you might have more departments that want to be part of the admission process. So it really just depends, I think, individually on each school and kind of what you want the end result to be, balanced with time. So with this last go around, it took us 2 days or 3 days to interview.
Just
2 days. But that was me and one of my full-time nursing faculty blocking out 2 days to interview all of our students, but we knew it was really valuable. And this next go around, we wanted to try to include other people in the college to be part of our interview. So we're gonna actually do a speed interview, I think, like speed dating, to try something different and fun.
But maybe even the policy stuff around prerequisites, or like, right, that seems like, oh, you made a policy decision about that, or like credit for prior learning, things like that, where it
We're
feels
still
like.
working on the credit for prior learning, because we're finding more and more that people are coming in with a big variety of experience that doesn't fit in our nice little, if you were a CNA, you get 2 points. So that is still a work in progress. And currently we're evaluating applicants on a case-by-case basis because we're not tied to having to make a decision strictly based on how many points someone has. So it's really great for us to, be able to look at the person as a whole picture. And when Dr. Joe and I were talking about ways to remove barriers, and I noticed when I was I was a floor nurse up until about a year ago, hearing people talk about, well, I would go to nursing school, but all my prerequisites are expired.
Yeah.
I started thinking, just because someone's prerequisites are expired, doesn't mean that they're not valuable.
Yeah.
And so we put it back on the students and we tell them during their interview, if they have older prerequisites, or if they haven't completed all their courses prior to starting, like that extra effort has to come on your part. Like if you're rusty on A&P and you're in your patho class and something doesn't make sense, like that's on you to review or get help. So we let students know we have resources here to help you. If you're rusty on something, like reach out. So, and that's my favorite thing that we did to remove barriers. Because I had a handful of students in our first cohort who otherwise would not have been able
that seems huge.
to go to nursing school because they were all working full-time too. Because that's also a reality of our students now. So to try to figure out how to meet people where they're at and support them on through is important. We don't dictate, kind of a side note, we don't dictate whether or not somebody can work full-time. Some nursing programs try to say, like, you can't work full-time. We look at their performance, and if they're not performing well, we meet with them and we have conversations and we have recommendations, but we don't dictate those things. We try to meet people where they are more than try to put them into the lane we want them in.
Thank you.
Yeah.
Just a quick follow-up. So just to clarify, the decision about prerequisites is one that is made at the program level, leadership level. That doesn't seem like something that would go to the board. So you can just make, and it's not regulated by the HEC. So That's a decision made at the program and leadership level?
Yeah.
Okay,
That's great.
great.
Yeah, because we decided what you have to do XYZ to apply to
Yeah.
our program.
Yeah.
So we get to
Amazing.
make those decisions.
Okay, I do have 3 real questions. I'll make them quick, but you go first.
So just a comment on this topic, because I think one of the challenges is the sheer number of applicants in some programs. And so some of these things that you're able to do actually like make sense, but when you're starting from a lower number, you don't have to weed out half your applicants.
Yeah.
And other programs are having to weed out literally half to 3/4 of their applicants because the interest and the number of students is so big. And so how do we, if there's, and probably a lot of those applicants would be qualified and you'd be great nurses.
Yeah.
And so the beauty of what you're able to do is you're able to, those students have a chance.
Yeah.
And in a lot of programs, those students may not have a chance because of the way that programs have to reduce their numbers. So how do we get the pipeline bigger?
Yeah.
So that we're able to give all those students the chances that they deserve, because again, some of the students would be great nurses.
Yeah, just
And
clear
what
out
you
for
did
those students.
was open up the unnamed organization up the road. Now to be able to take more students, because a lot of the students from Tillamook were potentially having to go up the road. So the more programs there are, the less, we don't have to cut half of them.
Mhm. Yeah, and something to add too, when you talk about pipeline, you also have to consider the capacity and the faculty that are required to teach. And then one of the things that is a challenge for us at Portland Community College is pay, because someone can make more out there as a traveling nurse, and then we're bound by our contractual obligations to pay within a certain. So there's some complexities and nuances also specific to the institution, that there's the pipeline need, there's the demand, and then there's the capacity, and there's the fiscal aspect, and there's so many other things that are, I heard someone mention, the clinical placement challenges that could arise too. So there's this whole mixed bag of challenges.
You'll find almost all nursing instructors, unless they're like retired off the floor and they don't want anything to do with being on the floor anymore, and they don't need or want those wages that the floor brings. Almost all nursing instructors also still work on the floor, at least in a part-time. I have another full-time job in addition to this, because I left the floor. I do stuff with insurance, which isn't very exciting, but it's not on the floor anymore. To address that, when you graduate from nursing school and you're making great wages as a floor nurse, it's really difficult to be required to have a higher level of education and step away from the really high wages on the floor.
Yeah.
So quick question, this balance of this being the newest nursing program, obviously pent up demand for nursing degrees. How do you balance the grow your own, take care of your own with the fact that you have folks applying from California and I imagine other parts of Oregon because they haven't been able to get into the programs in their own community? Are you starting to wrestle with that, or have you not had to prioritize it in that way?
One of the reasons we took 17 this new cohort was because we were kind of wrestling with, we wanted to really honor some NA students who finished our NA program and looked like really great candidates, but didn't have as much time as maybe the people who were coming in from out of state, because they were ready, they just couldn't get in. And that's one of the reasons we took 17. So in our point scheme part of our whole application process, they get extra points for taking classes at TDCC. They get extra points for either graduating from a high school in our county or being a resident here. So it's weighed a little bit in that way. But again, because we have the ability, because we're not stuck to just points, those are things that we can consider, make sure we're protecting our local community first, and then, bringing in other applicants that also make sense.
And that's very important that we keep that too. I mean, that's kind of our commitment to Gail and to Eric and to our partners, that we're going to grow our own, right? I mean, that's very important. and being able to recognize the talent that we have here and be able to develop the talent that we have here. So we don't have any more Sarahs, right? I mean, I think, because that's what happens, right? If you go somewhere else, I understand it, I get it, right? You're comfortable at the hospital you're working at, you've made connections.
Get a job offer.
Yeah. Right? So I think that we started this with that commitment in mind, and that this really is, and I would love if in my mind, I would love for our program that you would be able to look at our program and you couldn't distinguish this from TVCC versus Adventist versus Nehalem Bay. This is our community's program, right? And that we serve the community in that way.
Can I quick?
Yeah,
Or I think everyone has to be after too, but just saying that, so personally, I grew up in a small community in a quasi-rural area in northern Indiana where the main industry economy, there's an anchor hospital in that town that's like less than 20,000 people, right? So very like different but similar. And I am so just like heartwarmed to see this collaboration and this effort to do that, because I mean I went back there last year and not even 10% of the people that I went to school with stayed, because they're in the absence of things that were going away. Like we're talking about the resiliency, the vibrancy that stuff has gone away. And if there was something, because there is the capacity there, where people would have done the collaboration and care for that, like I maybe wouldn't live on the other end of the country, right? Maybe I would anyway, but I mean, it's pretty fun, yeah. But I just, and to the numbers, data, the lens that I look at a lot of it through, I mean, I think about it as a person, human, and somebody who needs healthcare myself. But also when you're doing things to expand the economic resiliency of an area and bring different industries and different balance there, it is helping sustain a community for the longer term. So just big props to all of you. It's really good to be heartwarming here.
Has Future Ready Oregon really enhanced your partnership collaboration in a way further? I know you guys work really well, but how has Future Ready Oregon grant helped that further your cause as collaborators? Has it helped to nurture and grow your collaboration model?
You've got to keep in mind too, that Future Ready Oregon did not come into play until April of this year. So our background is 5 months old. What the history and the impact that we can share with you, and there's still so much more to see of what will happen in the coming months and coming year.
And I'm assuming it is helping.
Well, yeah, and I mean, we've leveraged on Future Ready Oregon grants that we've gotten, whether it's been for credit for prior learning to jumpstart that here, or whether it's been career pathways grants that we have gotten. I think it's about leveraging one sort of funding source to get others. We would not, as I mentioned, we had community support for the construction of the new facility. Both Gail and Eric were really important and influential in helping to provide that bond. But we also had, we had a federal Title III grant that came in at about the same time, centered around growing a healthcare program and a nursing program. Still haven't heard if we're going to get our 5th year of that yet. So I'm nervous about that Department of Ed grant. But we had that. We had an appropriations HRSA grant that allowed us to fund mostly equipment and personnel to get the program started, right? Because we had to hire a lot of folks before we had a program to build the program. And so I think we've leveraged a lot of those resources, some of them being state Future Ready grants and other state grants, and some of them being federal grants, that we've been able to get to support this work.
And these partnerships are so deep and have been in place preceding Future Ready Oregon. Anyway, I just, in closing, very curious about your enrollment in other health programs. So we heard the MA program in the college up north is significant enrollment increases this year. Are you experiencing something similar? Do you expect the new nursing program to drive more interest in other allied health programs? What are you seeing in terms of enrollment?
This is actually funny because her and I just had a conversation very briefly about our MA program typically is bursting at the seams, and all of our programs started yesterday, except for the nursing assistant program, because that was a run in the fall. It's summer and then planned for spring. And the MA numbers are actually down, and we were actually just wondering, is that because people have now had enough time, because the nursing program, we're halfway through with our second cohort, so people, it's here, and so they're taking prerequisites, and maybe we're kind of diverting from, they would have chosen a different option, but they've been working on their nursing prerequisites. So because the nursing program is still so new, I think that remains to be seen. But we had to cap our EMT program because we were getting too many students in there for the faculty we had available. We want to make sure we can get good quality instruction. We broke our phlebotomy group into offering it twice a year instead of one big class for the same reasons we can have smaller groups. So everything still seems to be, with this weird anomaly of the MA program just this term, still very robust.
And very high numbers in prerequisite courses as well.
Yeah.
Well, thank you all for an engaging discussion, especially after lunch. It was engaging and insightful, so I'm glad no one had a food coma. And I'll turn it back over to you, Jennifer. Let's get back to
Thank you. So as our panelists are transitioning, just a reminder to folks that right after we wrap up, we'll just sort of convene over here, and Dr. I have been apparently saying your name wrong all this time.
I think your well sounds very elegant.
Okay.
I grew up with Gerald. So.
Okay. Yeah. Dr. Gerald will be leading us on a tour of the new building next door. So looking forward to that. If you can pull the slides back up, I just want to point out just some next steps for folks as we wrap up. There is a tentative meeting calendar in the slide deck. This is consistent. You can just keep going through the animation. Yeah, this is consistent with the same sort of day of the week of the month that y'all have scheduled the last 2 years. So I just did that for 2026. I will send that out in an email so that anyone can flag immediate questions or concerns. As a reminder, our winter meeting will be entirely virtual, so we don't have to worry about inclement weather. And that will tentatively be January 27th. We will continue the practice of having one meeting outside of the Portland-Salem area. So if folks have a part of the state where you have to visit your own members and you would like us to schedule around that, we can do that. But I think we found that for the other consortium, the summer meeting has been the most ideal for that. And for this consortium, it seems like the summer is the least ideal. So we may want to think about doing that in April or September. I mentioned that we're going to start working on a strategic work plan for 26-28, and Daria and I will sit down with some of the brainstorming that we've done today and start to build that out. And we'll be meeting with your leadership team over the next couple of months so that we can bring something to you in January to have some breakout discussions around. We talked about selecting a couple of occupations from the profiles and diving into a bit more of the opportunity mapping. I think Gail's presentation set us up really nicely. Your questions got us thinking about what do we know about supply and demand for the higher demand occupations? What does that look like for the different regions of the state? Well, how do wages play into that? Lots of conversation about barriers to accessing opportunities, but also advancement within opportunities. And if we can start to find some of those that can really inform our recommendations and next steps. And then continue to put in front of you this question about Future Ready Oregon project activities and how we're learning from that. So in January, you will hear our year 4 annual report. I messaged the team and said, we need to start talking about what we can say at this point related to outcomes and related to promising practices. So I continue to just elevate to all of you, if there are particular approaches or parts of the state or occupations that we want to dive deeper and start to pick those apart, bringing in grantees over the next several quarters is where that opportunity lies. So please let us know if there's something that you're just itching to know more about. Otherwise, those are what's on the horizon for all of us. This has been an excellent meeting. We at the HAC remain committed to being in community, giving you all as leaders the opportunity to hear from community partners, giving community partners the opportunity to access the leadership and decision-making in community. So I hope that this has been a robust opportunity for all of you as well, and can't wait to see the new facility next door. So thank you all.
Thank you.
Thank you.